appeared. There's a light above my head, sometimes white and sometimes red. Bright ideas make it glow, and very soon the rest of the world will know. I just came up with a really bright idea. I am so smart, suddenly it just appeared. I just came up with another bright idea. I am so smart, suddenly it just appeared. There's a light above my head, sometimes white and sometimes red. Bright ideas make it glow.
Hello, hello. Good morning, everyone. Well, if you're on the West Coast like me, I want to say good morning. Good morning from California. Everybody else, I want to say good afternoon. Welcome, welcome to our YT course for advanced coders. We are on week 4, and today we are going to be discussing everybody's favorite, the cardiovascular system. So again, I want to welcome you all. Thank you for joining us today. We have a lot of great stuff planned for you. And as you know, last week we had you all enter into a drawing to enter in for a 3-month access to one of our lecture series courses. So I just want to let you know that we will be announcing that winner at the end of class. Thank you all for your entries, and we are excited to announce who is the winner of our lecture series. So stay tuned for that. And I just want to go over with you guys, because I know we have some people inquiring about more about AMCI. We do offer a lecture series and fast track course. For those who are interested, you can visit us at www.amcicoding.com. Go ahead and click on the tab at courses on our main page there, and it'll bring it down a drop down menu here, and you can sign up. You can scroll down to lecture and fast track courses. Go ahead and click there. And this is a monthly subscription, so you can enroll for either the lecture series. With this, you can study on the go for both courses here. The lecture series, you can watch AMCI's private medical coding lectures. These are invaluable. I use these to study for my CPC exam, so they are great, and these have all been updated as well, okay, for 2018, and they are mobile device friendly, okay? Now with your fast track course, you can also, you have access to some final exams, and you receive a certificate of completion. And again, like I said, these are monthly subscriptions. Okay, and I want to introduce everyone today. I am Miss Tracy. I am the instructional team director and the intern director at AMCI, and I will be your instructor, one of your instructors today for the cardiovascular section. And I want to introduce Miss Rochelle. She is our partnership and marketing director here at AMCI. Hi, Miss Rochelle. How are you doing today? Good afternoon.
Hi, Miss Tracy. I'm doing great. How are you? And how are you, coders, YouTube friends all over the world? Shout out to our Filipino there. I think we do have some Filipino viewers right now too over here, Miss Tracy. So if you are from the Philippines, hello and mabuhay. Kumusta po kayo? And yes, I'm so excited. Can you believe it? We're now at week 4 and it's everyone's favorite topic. So cardiovascular CPT guidelines. Are you ready, coders? We're gonna be coding our hearts out today. Yay! And I'm ready, Miss Tracy. Thank you for the introduction.
Yes, yes, I love that. I love that. We're going to be coding our hearts out today. Indeed, we are. Indeed, we are. Thank you so much, Miss Rochelle. And of course, we have Mrs. J, our Director of Curriculum here at AMCI, and Mrs. J. Hello, good morning. Actually, good afternoon, Mrs. J.
Hello, how are you, Mrs. Tracy?
I'm
How are you?
doing well, Mrs. J. Thank you for
Awesome,
asking.
awesome, awesome. And how are you, coders? Are you doing well? Well, let me tell you, you did a fabulous job the last 3 weeks. And I want to tell you, we are so excited. I'm particularly excited because we're going to talk to you about cardiovascular, and it can't get better than that. So, Mrs. Tracy, I don't know if it's you or me. Is it you? Do you take
It
this?
is.
Okay.
Oh,
Well,
actually,
welcome, welcome, welcome. Oh, okay. Well, she's giving it to me. All right, I'll take it. Thank you. All right, so welcome, 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 everyone. Let's get started. And do you want to win an AMCI lecture series? And remember, we're going to be announcing last week's winner this at the end of this class. So if you want to win a lecture series too, this is how you do it. You need to comment on the video below. Tell us what you learned in today's presentation. Then at the end, we will give you a link. It's your sign-up link. Go ahead and click on that link and you will be entered into the drawing, and we will announce the winner during week 6, not next week. Week 6 is urinary. That's when we will announce the winner. Okay, let's get our fingers ready. All right, so I have a question for you. I want to know, how confident are you with cardiovascular CPT guidelines? If you're very confident, write it in the chat. If you're somewhat confident, write it in the chat. And if you're barely confident, write it in the chat, or something else, go ahead and write it in the chat. Let us know. We need to know how we can help you. All right, here are the class rules. We've been at this for 4 weeks, so I'm going to do it very quickly. This is a reminder that this is an advanced course, meaning the pace will be accelerated. And if you're in a comprehensive course, this class may be for you. However, if you are a new coding student, this class may not be for you. And if you would like a free course, we have a free course for new coders, and you have to be brand new because it's an introduction to medical coding course. Go ahead and click on the link, our customer service link, right in the description below, just below this lecture. Again, we've got playbacks. Feel free to watch them at any time. And there will be homework. And the homework, we have homework this week, not last week. We didn't have homework during respiratory because it's combined with cardiovascular. So you've got homework this week. It will be in the comments section after class. And let's remind you that students should already have some experience with CPT guidelines, especially in cardiovascular, because it can be a little intense. Here are the goals for today. Number 1, review the guidelines for cardiovascular section coding of your CPT manual. Number 2, provide scenarios to further clarify the more complex guidelines. Goal 3, provide CPT documentation tips. And finally, goal 4, demonstrate the importance of forensic reading. And don't forget, coders, class will move at a faster pace than usual. Here's the course outline. Week 1, we discussed integumentary system coding. Week 2, musculoskeletal. Week 3, respiratory. Week 4, cardiovascular. Week 5, digestive. Week 6, Urinary male female, 7. Nervous eye ear, week 8. Radiology anesthesia, week 9. Pathology, and week 10. Medicine. So these are all of the subjects that we'll be discussing throughout this entire course. However, today's class is cardiovascular. Now, we will not cover evaluation and management, nor ICD-10-CM or PCS, because those topics are a little more intense and involved, and we just don't have enough time to cover them. So, don't forget, coders, class will move at a faster pace than usual. And note, I know I asked you to put some things in the chat, but just remember, if you have questions, type them in the chat while keeping in mind that the instructor, the one that's speaking right now, that's me. I'm unable to see your questions. However, several of the AMCI instructors who are not speaking are standing by to answer your questions. So you will be able to identify the AMCI instructors because their names should read along with a picture or an image of an instructor, AMCI Mrs.Jay, AMCI instructor, Mrs. J, AMCI instructor, Ms. Rochelle, or AMCI instructor, Ms. Tracy, and we have several instructors all ready to answer your questions in real time. So make sure you ask questions that are pertinent to our discussion. That will give you the best result, I promise. All right. Let's read the copyright. CPT is copyright of American Medical Association. All rights are reserved. CPC is a registered trademark of AAPC, and content found within this presentation is copyright of AAPC. Keyword concept, FTR, CHUN, AMCI Fab 7 Flip Tap are all trademarks of AMCI. All right, so let's get started. And let's begin with the general surgery guidelines. For the last 3 classes, we've stopped here, we've started here, and we're going to start here again. And I just want to remind you that all CPT codes in the surgery section are a package, meaning there are multiple items bundled into it. In fact, there are 6 items bundled into the CPT code in addition to the surgery. In that code, the evaluation and management services on the day before and the day after are bundled into the CPT surgery code. Local infiltration or metacarpal, metatarsal, digital blocks, or topical anesthesia is bundled. Immediate postoperative care, including dictating operative notes, talking with the family and other physicians or other qualified healthcare professionals when a physician writes the orders, when the physician evaluates the patient in post-anesthesia recovery, and your typical postoperative follow-up days are all covered and bundled within the surgery code. So what does that mean? That means you do not code it separate. And if you have to, what do? If you said append a modifier, that is correct. Another thing that I want to draw your attention to is the term separate procedure. A separate procedure is a procedure that's denoted, well, it says separate procedure in the code language, and a parenthesis is around that word. So that means that that code, that separate procedure, should be coded by itself. Normally, under normal circumstances, you just code it by itself and that's it. However, it can be coded with other procedures as long as that separate procedure is not related to the more complex procedure or the other procedures. Okay, so typically it's coded by itself. You can code it with other procedures as long as it's not related. Now, if you've determined that it's not related to other procedures, you can go ahead and code it and just make sure you append modifier 59. All right, so that's it when it comes to general surgery guidelines. And yes, we have to trust guidelines. That is what this discussion is about, trusting guidelines. And there are 3 types of guidelines that we follow. Number 1, you've got parenthetical guidelines. These are guidelines that are found within parentheses. And some people call it parenthetical notes. At AMCI, we call it parenthetical guidelines because these are guidelines that take precedence over all guidelines. And if you see them as guidelines, you will treat them like guidelines and you will regard them as guidelines. And they are the highest ranking guideline of them all. The next in line are your code series or your chapter guidelines. And these guidelines can be found in the section just before the code series. And it's typically underneath the blue bold. Typically, just like what you see on your screen, the debridement. The third type of guideline are your general coding guidelines, and they are found within the green pages as we've just read, and these are your section guidelines, and we've just reviewed the surgery guidelines, and these are third in line. So first, parenthetical guidelines takes precedence over all. Next, your code series or chapter guidelines, and then finally, the general coding guidelines. And so if there are no guidelines, you know what rules? Your keywords. All right, so at AMCI, we have a procedure, not a procedure, but what is it? It's a method of evaluating scenarios for your exam where we show you how to abstract the keywords, and those keywords will drive you to the answer. You can use those keywords along with guidelines, and you can use them in lieu of guidelines, but remember, your guidelines will always take precedence over anything. Okay, sorry about that. All right, so we've done our due diligence, and now it's time to talk about the cardiovascular system. Are you ready? Well, if you aren't, you better get ready because I'm ready. All right, coders. In the cardiovascular system, the anatomy pretty much is comprised of coding for arteries, veins, and the heart. And you're going to need to know the anatomy of such. Now, yes, the arteries and veins kind of represent, you can kind of determine the arteries and veins by the body area in where the arteries and veins live. Let me go back. And I want to show you. And we know in this picture, this is veins because it's blue. And in CPT, veins are represented by the blue color to represent that they are not clean. Well, that's what I'd like to say. But if we look at a vein here, and in this picture, you see a femoral vein. And where is the femoral vein? Wow. Some people might say, well, it's near the femur. Absolutely. So that's pretty much how you can tell the location of veins and arteries. Not always, but it is one indicator. Now, when it comes to the heart, you're going to need to know the muscles within the heart. You've got your endocardium. That is there are three primary layers of the heart. But here you see 4. But I'll explain this to you in a moment. The 3 layers of the heart are your endocardium. That is the innermost lining of the heart, followed by the myocardium, that is the muscle around the heart, the epicardium, that is around the heart, that is above the heart, and the pericardium, The pericardium is around the heart. So epicardium, myocardium, and endocardium represent the layers, and the pericardium represents around that heart, okay? So, and specifically, it is a thin sac that surrounds the heart muscle. Also, you're going to need to know, and this is the most important, you're going to need to know the different vessels within the heart and also the spaces. So let me just give you a little bit of anatomy, just a little bit. You know, I like to stay away from that and give that to MC, our anatomy and physiology instructor. So the heart, as you can see, is a cone-shaped muscle about the size of an average fist, and it's located between the lungs and behind the sternum, which is your breastbone. So 2/3 of the heart is located to the left of the midline of the body, and 1/3 is located to the right. So it's almost in the center of your chest. And the role of the heart is to pump blood depleted of oxygen. Remember that dirty blood, that blue blood? It's depleted of oxygen, so it comes to the heart, and then to the lungs to become oxygenated or replenished, and then pumped back out to the rest of the body. The clean blood is pumped right back out to the rest of the body. So, we've got 4 chambers and 4 valves. And I think the next slide is a better picture. So the way that you should perceive or understand the anatomy of the heart is you need to understand the flow of blood through the heart. And the way to understand that flow is to understand the anatomy of the heart. So your blood comes to the heart through the vena cavas from the lower portion of the body. It comes to the inferior vena cava, and the upper portion of the body or upper extremities the blood comes to the heart through the superior vena cava. So after it goes through the vena cavas, it lands right here in the right atrium. And notice this blue line is blood. So it's trying to show you the blood coming in. So from the superior vena cava, you got your oxygenated blood or your dirty blood coming in, and it lands first in your right atrium. And from the inferior right atrium. Then, in order for it to go into the next location or the next ventricle, or well, the next location, we're just going to say location for now, of the heart, it has to go through a valve right here. See the valves? They're open. Yeah, that's a valve. And I like to call them doors. I like to say that they go through a room, then they start in a room, they have to go through a door to get in another room, and then that process just kind of repeats itself. So there are 4 rooms and 4 doors. The first room is your right atrium. The first door is your valve, and this is your I just had a brain. I'm just talking and talking and talking. Okay, so this valve right here is your tricuspid valve. And then it lands in the right ventricle. We're still on the right side of the body. And the next thing that it has to do is go through another door or a valve. And that valve is your pulmonary valve. And when you start talking about pulmonary, you know the pulmonary means the lungs. And it also means that's where the blood goes to become deoxygenated. Okay, so that's where they clean the blood. Yeah, in the lungs. And if you look at your blood color, see it's blue, 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 goes out through the lungs, in through the pulmonary veins, and look at that. It's red, and that means it is clean. And you know where it's entering? It's going into the left atrium. right here. This is the left atrium. It's a real small space. Then you got a door right here, or a valve, and this is your mitral valve or bicuspid valve, either or. And then you're going to land in your left ventricle. Then you got to go through another door, and that door, that's your aortic valve. And then it goes through the aorta into the rest of the body, nice and clean. All right, so that is the anatomy of the heart. And here you go, RTRPLMLA, right atrium, tricuspid valve, to the right ventricle, to the pulmonary valve, to the left atrium, to the mitral valve, to the left ventricle, to the aortic valve. Or you could say, if you take all those letters, you can create the acronym for right time, right place. Let's make love all the time. And you can make it sound like a heart too. Boom, 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 boom. Let's make love all the time. Okay, makes sense to me. Yeah. Okay, so as long as you know that the heart is divided into 4 chambers, the right atrium, the right ventricle, the left atrium, and the left ventricle, that is all you need to know. And then you know those valves, tricuspid, pulmonary, mitral valve, and the aortic, you're okay. You with me, coders? Okay. So the chambers, if you like acronyms, they're RAV-LAV. All right, so let's get started and let's learn about cardiovascular coding. We've got some notations that I need to show you because you will be looking at my CPT manual, the electronic version. So when you see this squiggly line, this means that the code has bundled items in it. When you see this plus, this means code separately or in addition to. When you see the X, this is a general do not code. When you see the circle with the line going through it or the do not sign, this means do not code, but it's specific, like do not use 62 modifier. When you see the asterisk, this means do not code, and typically I place this next to a parenthetical guideline. You'll see 2, and this is very, very important because remember, parenthetical guidelines reign supreme, and if you see something in a parenthetical guideline that says do not, that means that you do not do it, and it's often superseding or taking precedence over some existing guidelines. So make sure that you put whatever kind of notation you need to make sure that you follow that guideline when you see it. And finally, C guidelines. When you see those eyeballs, it means go ahead and read those guidelines. If you haven't read them before, go take a read. And that's it. All right, coders. So let's begin our discussion with coding pacemakers. A pacemaker system with leads. See these leads? These are wires. They include a pulse generator that includes battery. This is your battery. So a pacemaker is a pulse maker or a battery and wires. And the leads are known as electrons and wires and so forth. So that's pretty much all I really want you to get. A pacemaker system is a battery and wires. So let's take a look at batteries. In this picture, in these images, you see three images of people who've had batteries or battery skin pockets with batteries inserted. So as you can see, the first image is really, this person must be very small because you can see the entire imprint of that battery. There is no doubt in my mind that this person has a pacemaker or a defibrillator. Also, it can be placed here in the middle picture, right in the bra area, the side right before the breast, and they can be placed anywhere. As you can see, the third image, this patient had a pacemaker battery inserted in the back. Now we've got the wires. And the important thing that you need to know about the wires is the wires tell you how many chambers, or they describe the type of pacemaker or defibrillator you're coding for. So in example A, you've got a pacemaker. Well, this is actually not a pacemaker image, but it's good for this, what I'm telling you. But you see the wires coming through. The first, whew, you know what? This is really not the best example. So we've got one wire. These are both one wire. Okay, so this wire in a normal setting would stop right here, plant itself right here in the atrium. If it's a single, lead system, or it would be placed in the ventricle, both the atrium and the ventricle, if it was a dual lead system. So the number of wires tells you the type of system. It's an indicator. Now, the way those leads or wires are implanted is significant in coding too. You could have, the most common way is the least invasive way, and that's through the vein. Yeah, so they take a catheter and go right through the vein and place those wires where they need to go. If they can't do it through intravenously, then they will go through the chest. They will open up the chest thoracoscopically or thoracotomy. Thoracoscopically is through the chest through a scope. Thoracotomy is the cutting. They cut right through. And they'll place the leads epicardially. Yeah, around the heart. All right, so let's go ahead and talk about these guidelines. And there are several guidelines, but the guidelines, I think, really describe and help define the procedures. The key to coding successfully is reading the code language. All right, so here's our guidelines. Right here, under pacemaker or implantable defibrillator, it tells you that a pacemaker system is pretty much leads and a battery. There you go. Also, a single chamber pacemaker system is one lead in one chamber and a battery. A dual chamber pacemaker system are two leads, one in each chamber. Yes, atrial and ventricle, and a battery. And biventricular pacing is multiple leads or three or more leads. Often they'll have one lead in the right atrium, one lead in the right ventricle, and another lead in the left ventricle. A leadless cardiac pacemaker system is just that. There are no leads. And in addition to a pacemaker system, you'll be coding for defibrillators. And defibrillator has a different function than a pacemaker. A defibrillator has a shocking feature. So if your heart is not in normal rhythm, the defibrillator has the ability to shock it back in normal rhythms. And don't forget, your leadless cardiac pacemaker description is here, and this is the pacemaking system with no leads. So that is the new technology, and as you can see, you've got some new language too in between these inverted green triangles. And if you want to read up on it, you can find it on page 214 as well as page 215 in your CPT manuals. Now I'm turning the page and we're going to talk a little more about these systems. The definition of an implantable defibrillator is here. The electrodes and leads definitions are here, and some coding guidelines. Also, your biventricular pacing for defibrillators. When you want to remove transvenous electrodes, you've got some guidelines here. Guidelines surrounding the battery is here, and the battery is also regarded as a pulse generator. You can find these guidelines on page 215 of your CPT manual. And then on pages 215 and 16, again, we've got revision of a skin pocket guideline, your relocation of skin pocket guideline, as well as your skin pocket when it's performed as an explant of an existing generator, followed by replacement. So explant means removal, okay? And here are your skin pocket guidelines. And notice my blue coloring. I'm starting to label all of my writing blue because if you are studying for the CCS or other exams, sometimes they have requirements, and I know the CCS has a requirement that you can only use blue. I know where I took my CCS, you can only write in your book using blue because black is the color of the ink that they give you to take your test. Yeah, it's a different story, but you can only use blue writing or have blue or other color writings in your book, not black, any color but black. All right, so back to the regularly scheduled program. Here are some new guidelines about device evaluation. This is when they're going in to evaluate the leads and the leads function. And these pretty much may not be reported in conjunction with a leadless pacemaker, okay? And they may not be recorded in conjunction with pacemaker insertion and removal codes. Down below, here are your radiological supervision and interpretation guidelines. Your fluoroscopy, ultrasound, ventriculography, venography, fluoro, and your diagnostic lead evaluation without lead insertion guidelines. And then here are your general single lead, dual lead, and multi-lead definitions. And you can find them all on page 217. And last but not least, on page 216, I know some of you see charts and things and you kind of skip over them if you don't know what it is. Let me tell you really quickly what this is. This is or could be a friend when you're coding pacemakers and defibrillators. All right, these codes right in this section from here to here, these involve inserting of a pacemaker, defibrillator, or battery, or leads. So your insertion codes are here. Your removal codes are in this section. And down below, you have your removal and replacement section. So it's a good idea to kind of use this, refer to this chart after you've coded. After, if you have a scenario, go ahead, solve the scenario, then use this chart as a reference and you're going to see the value of it. Some people code right off of it and some people use it as a tool to confirm whether or not they have the correct answer. All right, so let's get started coding these pacemakers and I'm going to review the guidelines. So when you're coding, you need to know what you are coding for. Are you coding for a pacemaker system? A system are battery and wires. Or are you just coding for a defibrillator? Are you coding for a pacemaker? Are you coding leads, wires, battery, or leadless? What are you coding for? You'll also need to know the type of pacing system, if it's temporary or permanent. If it's temporary, the documentation should state it. If it's permanent, that is the default. If it's not mentioned in the documentation, if it's temporary or permanent, the default shall be permanent. Now, how are these leads implanted? One of two ways: transvenous, through the vein, or through the chest. Another guideline is how many electrodes or leads. Is it one? That's a single lead. Is it two? That's a dual chamber. Is it three? That could be multi-chamber or biventricular. Another guideline, you need to know if a skin pocket was created or not. Skin pocket creations and revisions are bundled in the treatment code. And finally, if you have skin pocket reposition, whenever you are explanting or taking an existing battery out, then you can code that. So you can code explantations of skin pockets, but you cannot code creations and revisions. All right. So those are your guidelines. And if you didn't get it and you're watching the playback, or if you are watching live, go ahead and watch the playback and pause it. And I've just told you all of the guidelines. So that's going to be a great thing when you're coding. It's going to be very, very helpful. And this is an image of your biventricular pacing. As you can see, you've got one lead in your right ventricle, you've got one lead in your right atrium, and you've got another lead in your left ventricle. Okay, so that's biventricular if you want to take a look at it. And we have a scenario. Are you ready, coders? Well, I hope so. I'm ready. All right, the answers: A, 33217, 33231 with a 51 modifier. B, 33224 and 33225. C, 33249, 33225, and D, 33217, 33231 with a 51 modifier, and 33224. A 54-year-old female retired professional dancer sustained a heart attack 3 months ago. She presents today for placement of a transvenous biventricular defibrillator system. Which codes best describe this encounter? Okay, coders, I want you to take a minute and a half and tell me which of the following codes best describe the encounter. Okay, coders, how are you? How did you do? Okay. If you said C, you are doing outstanding. All right, so let me show you how I got this answer. Let's first determine what the keywords are. You've got 54-year-old, heart attack 3 months prior. She's there for placement of a transvenous biventricular defibrillator system. All right, I know it's got a weird space, but you'll see why it's like that in a minute. All right, so let's get started. We need to know, what are we coding for? And that's why it's important for you to go back and write down the guidelines. And simply, when you're coding for pacemakers, if you just answer the questions in your if you answer write down the guidelines and then answer the questions as you go, and you'll find it so much easier. All right, so what are we coding for? We're coding for a transvenous defibrillator and a biventricular one at that. Okay, so let's look at A. It's saying that 33217 is incorrect. Let's look closely. This is the code for insertion of 2 venous electrodes, permanent pacemaker, or implantable defibrillator. Coders, we're coding for a system. This could be correct if another code was for the battery, right? So let's see why it's incorrect. It's saying this is incorrect because, see this parenthetical guideline? It says do not. And when it says do not, do not. Do not report 33217 in conjunction with 33231. And if we look at A, it's coding it with 33231. So therefore, we're going to eliminate A. And also, we're going to eliminate D. And guess what? Look at the parenthetical guideline below. It says, for insertion or replacement of a cardiac venous system lead, see these guidelines. So if you're doing leads only, that guideline would be relevant. All right, next, B 33224. This is the code for insertion of a pacing electrode, cardiac venous system for left ventricular pacing with attachment to previously placed pacemaker or implantable defibrillator pulse generator. All right, coders. This code is used if this is not the first time this patient has had a defibrillator, because it says with attachment to previously placed pacemaker or implantable defibrillator. This is the first time. We know it's the first time because the documentation does not specify. And remember when I said if the documentation doesn't specify, this will be a not only a look at me. I guess I'm getting old. Maybe we're talking about me, this 54-year-old. But if it is a temporary or permanent, the default is permanent. And also, if they don't tell you if it's an existing or if this is the first time, your default will be first time. So I don't want you to confuse the two. So if it's temporary or permanent and you need to determine which is which, if the documentation doesn't specify temporary or permanent, permanent will be your default. If the documentation does not specify if this is the first or subsequent, it will always be the first. Okay. All right. So 33224, there was no previously placed pacemaker system because it doesn't specify that. So it is wrong. Okay. So let's look at 33249. 33249 is correct because this is the code for insertion or replacement of permanent implantable defibrillator system with transvenous leads, single or dual. So we know this is a good code because it's coming up as good, but why is it good? It's good because This is coding for a dual chamber, and we've got a biventricular system. That means we have multiple chambers. And so multiple is 3 or more. So we have to code for the additional lead. And you can code it using 33225, insertion of pacing electrode, cardiac venous system for left ventricular pacing at the time of insertion of implantable defibrillator or pacemaker system or pulse generator. And if you look in the parenthetical guidelines, it tells you that you can use code 33225 in conjunction with 33249. Look at that. 33249 and 33225 is correct. All right, so I do want to go back. I think I kind of just went over that real fast, but I want you to look at it. And if you have any questions, go ahead and type it in the chat. And I've got one more scenario, and then we're going to move on to our next subject. And don't forget, coders, if you've written down those guidelines, it is your friend. Let me say them really quickly. Code what? What are you coding for? Pacemaker, defibrillator. What are you coding? Battery, leads, a system, or leadless. The type of pacemaker or defibrillator. Is it temporary or perm? How are they implanted? Were the leads implanted transvenously or thoracoscopically through the chest? How many leads are being implanted? And don't forget, skin pocket creations and revisions are bundled, and skin pocket explantations are coded separately. All right, now let's continue. A 33208, 33234 with a 51 modifier, 3323351, 33222 with a 51 modifier, 33214 with a 51 modifier. B 33208, 33214 with a 51 modifier, 33223 with a 51 modifier. C 33208, 33234 with a 51 modifier, 33233 with a 51 modifier, 33222 with a 51 modifier. D 33214, 33222 with a 51 modifier. A 51-year-old patient required a conversion of a single chamber pacemaker system to dual chamber system. The previous placed electrode was removed transvenously. The skin pocket was opened and the pulse generator was removed. The skin pocket was relocated and the dual system was replaced with transvenous electrodes in both the right atrial and ventricular chambers. The system was tested and the new skin pocket was then closed. The patient tolerated the procedure well. How to report these services? Okay, coders, I'm going to give you maybe 2 minutes to solve. Okay, I just showed the answer. I hope you didn't see that. All right, you got 2 minutes, coders. Okay, coders, so please forgive me for telling you the answer ahead of time. Hopefully you didn't see it, and if you did, my apologies. The answer is D. And if you said D without looking, outstanding. All right, look at that. Look at my bar. Bye. All right, so now let's review the keywords. 51-year-old, conversion, single chamber pacemaker system to dual chamber system, removed transvenously, skin pocket. Oh, look at that. I think we're out of order. But the pulse generator was removed, the skin pocket was relocated, and a dual system was placed in transvenous electrodes in both right atrial and ventricular chambers. All right, so coders, we have a green box around 33214. And I'm going to tell you why it's correct. But first, I want to outline some things. If you look at codes 33208, if you look it up, you'll see that this code is coding for the insertion of electrodes. 33234 is the code for removal of one lead. 33233 is the code for removal of a battery or pulse generator. And you know what? If you look at 33214, it's coding for an upgrade of an implanted pacemaker system conversion of single chamber pacemaker to dual chamber system. And when that happens, it includes the removal of previously placed pulse generator. So it's coding, the removal is bundled in the code. See, we wouldn't need to code for it. Off the bat, you see A is incorrect, and so is B. It also includes it includes testing of an existing lead and insertion of the new leads and insertion of a new battery. What? Look at that. So it codes for the removal of the leads, removal of the battery, placement of the new lead, and placement of the battery. So guess what? 33214 is a code. It's a good code that bundles everything. So we will be eliminating A, B, and C. And the reason why D is correct, because in addition to 33214, it says that the skin pocket was relocated. And you don't really code for relocations, but an explantation took place. Yes, the pulse generator was removed and relocated. So when they remove that battery, that is an explantation, and you can code the relocation of the skin pocket. All right, for your pacemaker. And the answer is D. And if you got that correct, outstanding. But if you learned something, coders, that's priceless. Now, really quickly, just want to show you that chart. Remember I told you about that chart? Here it is. So we got our answer. And if you look down here, upgrade single chamber system to a dual chamber system, it tells you that 33214 includes removal of existing pulse generator, and I love it. So it gives you some clues and it tells you how to code. All right, so without further ado, I'm going to hand it over. Am I going to hand it over? Is this me? OMG, this is me. I apologize. All right, coders, we're going to talk about coding cardiac valves. Remember, we talked about the anatomy of the flow of blood, and we had to learn about the anatomy within the heart, and we learned that there are 4 valves. Yes, so just to review, this is, you've got your pulmonary valve right here, your tricuspid valve right here, your mitral valve, and your aortic valve. And most of these, I think 3 of these, are commonly operated on, and we'll call these procedures, the most common procedure within coding that we are going to study the guidelines for are called TAVI, and these are transvenous procedures of the valves. And we're going to talk about it a little more, and we are going to look at these procedures because they are minimally invasive surgical procedures, and they pretty much repair valves without removing them. Yeah. So, just in general, it the valve, the replacements are wedged in between the diseased valve, and we call these transcatheter aortic valve replacement, transcatheter mitral valve replacement, and so forth. All right, so are we ready to learn about those guidelines? I hope so, because these have a lot of guidelines. So if you want to employ your eyeballs, just put them in your book to tell you to go look at it if you need to. That's good, but I want to quickly show you some key guidelines. When you're coding for the aortic valve, it requires 2 physicians, all right? And these physicians will operate in tandem. So they all components of the procedure, and aortic valve is requiring of modifier 62. And within your aortic valve procedures, they bundle quite a bit. They bundle placing the access sheath. They bundle balloon aortic valvuloplasty, advancing the valve delivery system into position, repositioning the valve as needed, deploying the valve, and a temporary pacemaker insertion. That's bundled. Also, angiography, radiological supervision, and interpretation, that is bundled too, and that's done to guide. It serves as guidance for the procedure. Now, when you have diagnostic left heart catheterization procedures, you do not code it with TAVI or TAVR, TAVR, TAVI. You should not code it with it for the purpose of contrast injections, aortic left ventricular outflow intact measurement for the TAVI, TAVR, or post-TAVI, TAVR, aortic or left ventricular angiography. You do not code it. However, you will code diagnostic angiography if it's performed at the time of the TAVI, TAVR, if and only if no prior catheter-based coronary angiography study is available and a full diagnostic study is performed, or if a prior study is available, but as documented in the medical record as the patient's condition with respect to the clinical indication has changed since the prior study, or there's inadequate visualization of the anatomy and or pathology, or there's clinical change during the procedure that requires new evaluation. And D, for the same session, same day, diagnostic coronary angiography services, you got to report using 59 modifiers. So I just remembered that I don't think I was very clear in terms of what a TAVI is and a TAVR. The TAVI is transcatheter aortic valve implant, and TAVR with an R is a replacement, just so that that's clarified. All right, we got some more guidelines when it comes to diagnostic coronary angiography. You can code it. Okay, so it can be coded separately, diagnostic coronary angiography, when coding these TAVI and TAVRs for the aortic valve. And other cardiac catheterization services can be reported separately if these are performed for diagnostic purposes that are not related to the TAVI, TAVR, TAVI, TAVR, okay? And you will code additionally, percutaneous coronary intervention, PCI, that's your balloon angioplasty, your stents, and so forth. You also will code additionally transcatheter ventricular support. All right. And you will code also balloon pump insertion. So here is your guideline. All right, coders, get your pens and paper out. Here are your guidelines for coding aortic valve procedures, specifically your transcatheter aortic valve implantation and transcatheter aortic valve replacement. All right. Guideline number 1, this requires 2 doctors, and you have to use modifier 62. Guideline number 2, angiography, radiological supervision, and interpretation are bundled. PCI, percutaneous coronary intervention, coded separately. And you need to see the guidelines for coding diagnostic heart cath procedures because it's got some conditions. Diagnostic angiography are coded separately only if performed during a separate non-interventional session. Now, when I'm saying diagnostic angiography, okay, that's diagnostic, not therapeutic. And code separate other cardiac caths not related to TAVI-TAVR, okay? And then you can code additionally your transcatheter ventricular assist and balloon pump. All right, coders, those are your guidelines for coding your aortic valves. The next valve, you know we have 4 and you have guidelines for 3 of them. The next valve is your mitral valve. Yeah, we have guidelines there too. Little different than coding for aortic. Your mitral valve procedure is called catheter mitral valve replacement. So you replace the mitral valves. All right, and you've got pretty much 2 codes, 334, 18, and 19. And they are reported once per session. Here are the bundled items. Angiography, radiological supervision, and interpretation are bundled. And when it's for the purpose of guiding, as a guiding device for placement, you will use the bundled code. Also, diagnostic right and left heart catheterization codes should not be coded with 334, 18, and 19. And they should not be coded for the purpose of contrast injections, left ventricular angiography to assess mitral regurgitation for guidance of TMVR, or right and left catheterization for hemodynamic measurements before, during, and after TMVR for guidance of TMVR. And when you're coding for diagnostic right and left heart catheterizations, you code them additionally if no prior study is available and there is inadequate visualization of the anatomy, and if the patient's condition with respect to the clinical indication has changed since the prior study, or there is a clinical change during that procedure. You will code other cardiac catheterization services separately. They can be reported separately if not intrinsic to the TMVR for the same session, same day, diagnostic cath, and then you have to use modifier 59. Diagnostic coronary angiography is coded separately if it can be reported separately from an interventional procedure. As long as it's separate from an interventional procedure, you can code percutaneous coronary intervention. I missed that. Your PCI It's reported separately, definitely. Also, when you have transventricular support, you code that separately, and you code cardiopulmonary bypass separately. All right, coders, here are your guidelines for coding mitral valve. Number 1, which valve are you coding for? Are you coding for aortic, mitral? What are you coding for? Guideline number 2, report these codes 33418 or 33419 once per session. Guideline number 3, PCI, percutaneous coronary intervention, is coded separately. Guideline 4, for diagnostic heart cath, make sure you see those guidelines to read up on it to see if it falls within the specifications. Guideline 5, diagnostic angiography could be coded separately if performed during a separate non-interventional session. Number 6, code additionally transcatheter ventricular support and cardiopulmonary bypass. All right, coders, those are your guidelines for mitral valve procedures. And finally, pulmonary valve. Your code, you have one code, it's 33477. It's coded once per session. These are the bundled items within the code. You got some new stuff, some new bundled items. And do not report 33477 with the following. So you've got some things you need to look at. And also you've got some additional items bundled in 33477, such as your percutaneous balloon angioplasty of the conduit treatment zone, valvuloplasty of the pulmonary valve conduit, and stent deployment within the pulmonary conduit or existing bioprosthetic. You know what, coders? PCI is not coded separately with a pulmonary valve, just to let you know that. And do not code 33477 with 37236, 3797, 92997, 92998 for pulmonary angioplasty, valvuloplasty, or stenting within the prosthetic valve delivery site. And 929, 97, and 98 may be reported separately when pulmonary artery angioplasty is performed at the site separate from the prosthetic valve delivery site. And I know, coders, I know you're saying, oh, this is a lot, Mrs. J. Yes, but if you put little eyeballs to denote that you should read the guideline, it's really not a lot. And to be honest, when you're coding for this exam, this is not that involved. All right, so you can code these additionally when pulmonary artery stenting is performed at the site separate from the prosthetic valve delivery site. You do not code diagnostic right heart catheterization if the following has taken place. Contrast, you don't code it to report contrast injections, angiography, road mapping, and or fluoroscopic guidance for TPVI, transcatheter pulmonary valve implantation. You do not use code diagnostic right heart catheterization with pulmonary conduit angiography for guidance of TPVI and right heart catheterization for hemodynamic measurements before, during, and after TPVI for guidance. Diagnostic right and left heart catheterization codes, you can be coded separate if no prior study is available. A prior study is available but documented in the medical record. There is inadequate visualization of the anatomy and or pathology. The patient's condition with respect to the clinical indication has changed since the prior study. And finally, you can code it when there is a clinical change during the procedure that requires new evaluation. All right, so that diagnostic right and left heart catheterization is something that you need to come back and look at. All right, so you code other cardiac catheterizations separately when performed if intrinsic to TPVI and for the same session, same day diagnostic cardiac catheterization services. Make sure that you use modifier 59 and diagnostic coronary angiography performed at a separate session from an interventional procedure may be separately reported when performed. Okay, coders, get your pencil and papers out because here are your guidelines for coding the pulmonary valve, the TPVI code 33477. Guideline number 1, which valve? Guideline number 2, report once per session. Guideline 3, cardiac caths, contrast, fluoro, angio, I'm saying RNS, radiological supervision and interpretation, guidance image are all bundled. For diagnostic and other heart cath procedures, make sure you go see the guidelines. Diagnostic angiography are coded separate only if performed during a separate non-intervention session. All right, coders, if you're worn out, I understand because I'm worn out too. Just so you know, don't forget you've got 4 valves and 3 are the ones that you code for. You're going to code for your tricuspid valve, your mitral valve, and your aortic valve. And these images show you the first is a healthy valve, followed by a diseased valve. That's what a diseased valve, and in this picture right here, this is an artificial valve. This is how they replace. All right, coders, are you ready? Are you ready? I'm going to read this scenario.
Mrs.Jay?
Yes.
I can read it for you to give you a little bit of break, Mrs.Jay.
Come
That would
on
be
with it. Yeah,
fine. Okay,
thank
let's
you.
do it. You're very welcome. Okay, coders, let's put those guidelines into practice with this scenario. We have answer choice A, 33361 with modifier 62, 33368 with modifier 62, 76998 with modifier 26. For B, you have 33405. For C, you have 33364 with modifier 62. 76998 with modifier 26. And for your answer choice D, you have 33364 with modifier 62 and 33368 with modifier 62. A 58-year-old stockbroker with a history of chest pain, palpitations, and loss of consciousness presents for evaluation. After study, the cardiologist diagnoses him with left ventricular regurgitation due to the improper use or improper closure of the aortic valve. The patient arrives to the OR for aortic valve replacement with a prosthetic valve. The patient was properly prepped, draped, and anesthetized and placed on cardiac bypass. An open incision over the pelvic artery enabled access to the iliac artery. A compressed prosthetic aortic valve is passed into the iliac artery and advanced to the heart via catheter. The space is prepped with a balloon catheter. Via ultrasound guided imaging, the valve is positioned and placed at the site of the damaged aortic valve. After testing, the catheter is removed. The patient is weaned off, bypassed, and ablated to recovery. Which procedure code or codes best describe the physician services for this encounter? And we're going to start the clock for a minute and a half, and it's starting now. Mr. J, I might need you to give me one click to start the clock, please. All right, go ahead, coders. Good luck.
Okay, thank you, Ms. Rochelle, for saving me. She could tell I needed a drink of water. Thank you so much. Coders, how did you do? How did you do? If you said, I'm going to give you a few more seconds to get your answer in the chat. D, outstanding. All right, here's how we arrived at our answer. We've got the key words, 58-year-old, left ventricular regurgitation, improper closure of the aortic valve, the aortic valve replacement with a prosthetic valve, cardiac bypass, open incision, access to the iliac artery, prosthetic aortic valve, passed into the iliac artery via heart catheter, ultrasound guided image, valve placed, catheter is removed, patient weaned off bypass. These are my keywords, and I agree with them. Great job, Miss Rochelle. She does a lot of these, and she's phenomenal. All right. If you look at 33405, this is the code for replacement aortic valve open. Now, this is not an open procedure, even though an open incision happened, but that incision was just for the purpose of allowing the catheter to approach. Okay, so that was just, that incision was to enable the catheter, enable access to the iliac artery. Just to let you know that. And if you didn't know it, I'm going to show you another reason why it's incorrect. So this procedure was done transcatheter. It was a transcatheter placement or replacement or replacement of a valve. All right, and our keyword is catheter. That catheter was removed at the end, so B is incorrect. Now, A is incorrect because you see, coders, when you start coding a lot, that's why this is an advanced class, you know that when you see 7, that's coding from the radiology section. And often when you're coding from radiology, if you look up this code, you'll see that it's coding for your guidance. And you know what? You do not radiological supervision and interpretation are bundled. See that 26 modifier? You know that's your professional component, and we know that radiological supervision and interpretation are bundled. So there you go. We're not going to code anything from the radiology section with its 26 modifier. So both A and C are gone. And finally, that leaves us with D, 33364. If you look up the code 33364, this parent says this is transcatheter aortic valve replacement, TAVR or TAVI, VI, with prosthetic valve, open iliac artery approach. Isn't that how we approached our procedure? Yes, access to the iliac artery, and it's open. Yes. Okay, coders. And also, 33368 is your code for your cardiopulmonary bypass. And the patient was placed on cardiopulmonary bypass. So, coders, D is your answer. 33364 with a 62 modifier, 33368 with a 62 modifier. Coders, remember our guidelines? It told you when you're coding for the aortic valve, 2 surgeons are required. So it's really important that you reference and have your guidelines handy when coding. All right, now coders, if you got that correct, you did an amazing job. And if you learned something, that's even better because it's priceless. And with that said, I want to hand it over to Mrs. Tracy.
Wow, wow, wow. Thank you so much, Mrs.J. Y'all, give Mrs.J some love in the chat. Wow, that was amazing, the explanations that she gave on all those sections. I know that was a lot of talking, but Mrs.J always does it. She does a great job of it. So thank you so much, Mrs.J. And I'm going to go ahead and move on, and we're going to talk about CABG procedures, okay? And this is our coronary artery bypass graft procedures. So a CABG, we'll just say CABG, is a type of surgery that improves the blood flow to the heart. Surgeons use CABG to treat people who have severe coronary heart disease, or CHD. And that's just a disease in which a waxy substance called plaque, or you'll also hear it referred to as arteriosclerosis. It builds up inside the coronary arteries and that causes blockages. So basically for this procedure, the way it's performed is the surgeon is going to perform this by placing or attaching a vein or artery over the diseased coronary artery to bypass that diseased area. And what that does, it just reestablishes the oxygen-filled blood flow to the heart muscle. And as you can see in the illustration here, typically that bypass graft is attached to the aorta and it's carried down to bypass the diseased coronary artery. Okay, so you can see the blockages there and how that artery is just bypassing. And you can tell, it's good, we have to know on when we're coding for CABG, we're gonna get into the guidelines, but whether you're using an artery or a vein. So in this one here, you can see an artery is being used and also a vein, okay? Alrighty, so that would be called a combination. All right, so let's go ahead and move on to the guidelines. And these guidelines are very specific. So that's why I said it's really important to know whether you're coding for an artery bypass, arterial bypass, a venous bypass, or a combination, okay? If you're just coding a venous bypass, you're gonna be coding from this first column here, this first set of guidelines, and that's gonna be code range 335, actually this is 33510 to 3351. Wait, sorry, I think I'm saying that right. Give me 1 second. Okay, so these, so if you're coding arteries and veins, you're gonna see the combination codes 33517 to 33523. Give me 1 second. I just wanna look this up real quick because I think I might be saying this incorrectly. Okay, so venous grafting only is coded from code range 33510 to 33516, okay? So down here at the bottom, okay? So veins only 33510 to 33516, okay? Now, if you're coding a combination, you're gonna be coding add-on codes. So if it's a combination of arterial and venous, you're gonna be coding from 33517 to 33523. Okay, those are your combination codes. All right, so there's some things that are going to be bundled. So if the saphenous vein is used, so the procurement or the harvesting of that saphenous vein is included in that code range 33510 to 33516. Okay, so do not report those separately. Now, however, if you're going to be harvesting an upper extremity vein, you're going to use code 35500. Okay, so you see your little plus sign there. If you are reporting a FIMPOP, if you're using the FIMPOP, it's going to be 35572. And if there is a surgical assistant that performs the graft procurement, you're going to add modifier 80. Okay. All right. Now the same thing goes. The same guidelines kind of apply for each of the next guidelines we're going to talk about. However, the middle column here, this is your combined arterial venous grafting. Okay, so there's codes for the arteries. And then again, if you're going to be coding a combination, you're going to be using that add-on code 33517 to 33523 for the vein. And the vein, when you're in a setting of a combination CABG, you're going to always code the artery first and the vein goes second. Okay, and that's kind of a giveaway when you see those add-on codes, because we know those add-on codes can never be first listed. Okay, and again with these, the procurement of the saphenous vein is included. If there is if there's an upper extremity artery, such as a radial artery, that's procured. If it's an artery, you're going to use 35560, so you would code that in addition. And if it's upper extremity vein, you're going to use code 35500. And again, for the FemPop, it's 35572. Okay, and then if a surgical assistant performs the procurement, you're going to append, they would append modifier 80. Okay. All right, and then just for our arteries over here on the third column, basically follows along the same guidelines, okay? So again, the saphenous vein is going to be included. If there is an upper extremity artery procured, you're gonna use those additional codes, okay? So just watch out for that in your documentation. And then again, the modifier 80. All righty. So let's go ahead and move on and let's talk about some of the guidelines for this section. Okay, so first of all, if you see at the top, you want to know what type of graft you are coding. Is it a venous graft? Is it a artery? Or is it a combination of those two? Also, you want to know the number of grafts and if they came from the upper extremity or the lower extremity. Okay, so as you see in these illustrations, you'll find these illustrations on page 229 and 230. And if you see in the first one here, that's a venous graft. So what type of graft? In that one, that's venous. How many? Just one there. If you look at the middle picture, we have 3. So that would be a triple bypass, triple venous bypass. And then if you look at your third there, we have a combination. Okay, we have a venous and an artery. Okay. And for upper or lower extremity, the upper extremities aren't used as often, but if it is, remember we have those codes. So if it's an upper extremity vein, it's going to be 35500. If you're procuring or harvesting an upper extremity artery, it's going to be code 35600. Okay, the lower is bundled with the exception of that FemPop, which would be 35572. All right, so and typically you'll see this greater saphenous vein be used for harvesting. You'll see that a lot in your scenario, just because if you look at this, that saphenous vein is pretty long and hardy and it can be cut up to create several bypass grafts, okay? So when that is procured, we do not code it separately, it is bundled. All right. Okay, so let's move right along. And I just wanted to show you a little snippet from our CPT manual. I always say on these codes 33510, always box, you know, when it says vein only there, remember if you are coding a combination, if there's arteries involved in your CABG, we do not code from this section. You're going to use the add-on codes down here at the bottom, starting at 33517, okay? So you might just want to write up at this code family, not used for a combination or something, and then you might want to just box vein only there, okay? And then at this, the start of this code family, I usually just put something, you know, I write in here, combination of veins and arteries, just something that's going to help you to remember. And again, remember when you're coding for a combination, your arteries go first, followed by your veins, okay? And here are some of the common upper extremity arteries and veins, and you'll see them. So if we're using a radial artery or brachial artery, we're going to use that code 35600. If it's any of the following brachial of the veins, brachial, ulnar, cephalic, basilic, brachiocephalic, or subclavian, those would all be get code 35500. Okay. And there's just a little diagram of your upper extremity arteries and veins. Okay, moving right along, I have a scenario for you, so let's get right into it. We have A, 33534, 33516, 35600, B, 33534, 33510, 35600 times 2, 35500, C, 33534, 33517, 35600 times 2, or D, 33534, 33517, 35600, 33500. Patient undergoes a triple bypass. The grafts were procured from the radial artery, internal mammary artery, and the saphenous vein. What is or are the correct procedure codes for this encounter? All right, everyone, I will give you 1.5 minutes and your time begins now. All right, everyone. Go ahead and place your answers in the chat. How'd you do on this one? All right. So let's go ahead and look at these answers. When I look at my answers here, and I know we're coding for a cabbage, looking for some specific things. So I see all my first listed codes are the same, so that's good. And then I see my second listed codes are the same with the exception of answer B. So that's my oddball there. I want to take a peek at that. And then we have some additional codes, 35600 and 35500. And if we know the guidelines, we know what those are coding for. So let's go ahead and take a peek at I guess the keywords are coming up. So we have triple bypass, radial artery, internal mammary artery, and saphenous vein. So let's go ahead and look at this. So what do we have? Remember, if we have an upper extremity artery or vein, those get coded separately. So the first thing that I want to look at here is I have a radial artery, an internal mammary artery, and a saphenous vein. So the only thing that I see as far as an upper extremity artery here is going to be that radial artery. So I know that that's going to need a separate code, okay? So we also are coding for a saphenous vein as well. Oops, sorry. Okay, so I know that I'm going to have a combination. We have arteries and veins here. So that 33510 that I said is our oddball there, let's go ahead and take a peek at that. So that it's for a coronary artery bypass vein only. Remember, we don't use that set of codes if we are coding a combination, as in this case we are, because we have a combination of arteries and veins. So in this case, this 33510, I can get rid of it because, and like I said, in the combination setting, we do not code those vein only codes. Okay, so go ahead and get rid of answer B. And so the first column there, we're coding arteries. Our second column is going to be the combination, which is the veins, those add-on codes for the veins. And our third column is for the harvest. So let's go ahead and look at what was harvested. So we had a radial artery, an internal mammary artery, and a saphenous vein. However, the saphenous vein is going to be bundled. The radial artery, as per our guidelines, is coded separately. And this internal mammary artery, these are the most common bypass grafts that are used because they've just been shown to have the best long-term results on patients. And these arteries can typically be kept intact at their origin which is really good because they have their own oxygen-rich blood supply. So anyways, basically that is actually not coded separately. That is not a upper extremity artery or vein. That is going to be bundled as well. So the only thing we're going to be coding here is going to be for the radial artery, okay? So we only have one harvest that we're going to be coding, all right? So the internal mammary and the saphenous are going to be both bundled, and we just need one harvest for the radial artery. So if we see an answer C here, we have it coding for 2, okay? So right away, I know that that's wrong because I'm only going to be coding one harvest. All right, and the next thing is that the 33500. And again, the saphenous vein is going to be bundled, so that's going to be incorrect, and A is going to be the correct answer, okay? All right, everyone, talk to us in the chat. Let us know how you did on that one. And I'm going to go ahead. I think I have one more for you guys. Okay, we have our answers: A, 35571 modifier RT, B, 35571 RT modifier 35572, C, 35556, or D, 35556 35572. A 53-year-old executive chef with a history of coronary artery disease, status post coronary artery bypass 5 years prior, today presents with posterior tibial pain. Prior diagnostic testing revealed blockage of the right popliteal artery, and the patient was diagnosed with peripheral artery disease, or PAD. The patient arrives to the OR for bypass grafting. The great saphenous veins were not available due to the prior surgeries. The assistant surgeon previously harvested the cephalic vein, which arterialized for several months prior to this surgery date. The patient is prep draped and anesthetized. He was placed in prone position for the procedure. The surgeon incised to the knee to access the popliteal artery. Tissues and vessels were excised for exposure of the site for anastomosis. The previously harvested graft was attached to both ends of the target site. The incisions were closed in layered fashion. What procedure coder codes best describe this encounter? And I'll give you a minute and a half, and your time begins now. Good luck, coders. Okay, that is time, everyone. Go ahead and get your answers in the chat. Okay, and let's go ahead and look at these answers. So I see a split between 35571 and 35556 for our first listed, and then I see an additional code of 35572. Can you guys recognize that? That's our FemPop harvest. Okay, so that's just some things to think about. And our answer is going to be A. Okay, let's find out why. My keywords are 53-year-olds, history of coronary artery, status post coronary artery bypass 5 years prior, posterior tibial, peripheral artery disease, bypass grafting, previously harvested the cephalic vein, prone position, incised knee, popliteal artery, graft, and I think that's all I have. Graph attached. Okay, so let's go ahead and look at the difference between 35571 and 35556. So 35556 is coding for a bypass graft of the femoral popliteal. Okay, does it mention anything in our scenario for a femoral popliteal? I don't see anything. I do see a popliteal. However, says that this patient is coming in with posterior tibial pain, okay? So this is not at the femoral level. So we are going to go ahead and get rid of 35556, okay? So get rid of 355, so answer C and D, okay? So 35571 is coding for a popliteal tibial, perennial artery, or other distal vessels, okay? And if you look at distal vessels, this popliteal actually shows up as a distal vessel as well, okay? But it's saying that the patient came in with the posterior tibial pain and they're accessing the popliteal artery here. So this is where we want to be coding 35571, okay, for that popliteal artery. All right, so the difference between A and B is going to be that additional code, which is the harvest of the FemPop vein. And again, that was not harvested. It did say that there was a harvested cephalic vein, but that was harvested several months prior. So we are not coding for a harvest here. We're definitely not coding for the harvest of the FemPop because that wasn't performed. So we're going to go ahead and get rid of answer B, and that would make A the correct answer. Okay. So how'd you all do on that one? If you didn't get it correct, that's okay. But as long as you're learning, that's what matters. And I think Miss Rochelle has some more great stuff for you. So whenever you're ready, Miss Rochelle.
Yes, I do. Thank you, Miss Tracy. I love that discussion on cabbage. Great job, Miss Tracy. And coders, great job on that, on coding those exercises. Okay, at this point, we are going to talk about arteries and veins. So I think we already pretty much know this. So I'm just going to go over this pretty quickly. So you have your illustration here of your arteries and veins. Those are your two main types of blood vessels in our body. And as we know, artery carries the oxygen-rich blood away from the heart, while the veins carries low oxygen blood um, back to your heart. Okay, so we're gonna go ahead and talk about thrombus and embolus next. So normally, like I said, those veins carry your blood throughout your body, but there are some instances wherein a blood clot, as we know that a blood clot is typical or very useful whenever we're having a surgery. So our normal people would usually, um, it's body's way of keep saying sorry. It's a body's making sure that the body is going to clot so that you will not bleed out. Typically, I'm putting that in the layman's term, so I apologize for that. But anyways, what I was trying to say is a blood clot is a clump of blood that has changed from a liquid to a gel-like or a semi-solid stage, which sometimes could travel into your veins or your vessels. And when that happens, it can be or it can cause complications. Okay, so there's two types of blood clots. We have your thrombus and the embolus. And the way to determine them is that a blood clot or a thrombus is a clot that doesn't move. So the clot is stuck in your vessel like so. And an embolus is a clot that is moving in your vessel, and sometimes those embolus would lodge into a smaller vessel, and that can cause complication. And as far as treating them for thrombus, the way they treat that, or the way they will irrigate that clot, is through a thrombectomy. And for an embolus, the way they're gonna irrigate that clot is going to be embolectomy. So that's what we're going to be talking about next. So an embolectomy again is, give me 1 second. I think I'm okay. Here we go. An embolectomy is the emergency surgical removal of an emboli, which are blocking blood circulation. It usually involves a removal of a thrombi like so, whereas a mechanical thrombectomy or a thrombectomy, simply said, is the interventional procedure of removing a blood clot or a thrombus from the blood vessel. Now, when we're talking about medical coding or coding this, you have to pay attention to the following guidelines. So if you want to take notes on this, I'm going to give it to you. What you need to watch out for is, first, you have to know, are you coding for artery or are you coding for vein? You also need to know, where is the clot located, okay? And how was the clot being accessed? You also have to remember that. And closure is bundled in open procedures. And the key here also is to know the difference between an embolus or an embolism, the clot that moves, like we talked, and a thrombus, which is a clot that does not move. And that's it. So let me know if you got that. And then I'm going to move along to one more guideline over here. So for arteries and veins, just know that sympathectomy, when done, is included in the listed aortic procedures. Okay. And I think that's it. I think we're all ready to solve a scenario here. So I'm going to bring it to you. We have A 35302, B 35372, C 35363, and D 35372 and 35371 with modifier 51. A 45-year-old gym teacher who had frequent bouts of acute leg pain was recently diagnosed with coronary artery disease with femoral artery plaque. She arrives today for a thromboendarterectomy. The patient was placed in supine position, then properly draped and anesthetized. An incision was made over the groin area to enable access to the femoral arteries. Vascular clamps were used to close off blood flow to the diseased area of the deep femoral artery. The inner lining of the artery was removed. Endarterectomy was performed to remove a portion of the diseased femoral artery. A homogeneous patch graft was applied, and the surgical site was sutured closed with an 8-O propylene or polypropylene glue. The clamps were removed to restore normal blood flow. The skin incision is closed in layers. Which procedure code or codes best describe this encounter? All right, coders, let's get coding, and I'm gonna put in the time, and it starts now. Good luck. All right, coders, how are you feeling about this scenario? I have a feeling you're doing great on this one. So let's go ahead and take a look at our answer. It's going to be B. If you got it, great coding. If you miss it, don't worry. Let's go ahead and take a look at this one together, okay? First, like we always encourage our students, we want to watch our keywords. So we have a 45-year-old, acute leg pain, coronary artery disease, femoral artery plaque. Okay, we need to know our location there. Thromboendarterectomy, that's the procedure. Incision, femoral arteries. We have vascular clamps involved, diseased, deep femoral artery. Okay, really need to look at that. Artery 2, we have endarterectomy, remove, and diseased femoral artery. What else? We have homogeneous patch. Okay, we definitely need that. So if we look at these answers here, basically we're looking at this family. So we're just gonna have to we call it be forensic in our coding here. So we're gonna have to make sure that our scenario matches our keywords or and our keyword in our code description rather. So we're looking at this family code here, 35301 for thromboendarterectomy. We like that. That's what we're looking for as far as our procedure goes. This includes patch graft. We like that as well because there was a patch mentioned in our keywords as well. Okay, so we like that so far, but we have to determine our location. Okay, so the first one that comes out here is that if you look at 35302, same procedure with patch, but this is coding for a superficial femoral artery. We know by our keywords that we are coding for the deep femoral artery, so that one would eliminate your answer A. Okay, same also goes with that 35363 on your answer C there. Same procedure here, but this is for a combined orthoiliofemoral location there. Again, this is not what we're looking for. So we're going to go ahead and eliminate C as well. And D is 35372, which we're going to be looking at. But remember that the closure is going to be bundled in this procedure. And this one is gonna be wrong, that 35371. Also, that's for common femoral as well there. And we are just gonna be looking at to code for the deep femoral artery there, okay? So you cannot code both. One, that common femoral is not gonna be the right answer. So we're gonna eliminate D, and our answer is 35372. So just to quickly break down again for you, thromboendarterectomy including patch, and you're gonna pick 35372 code for deep profunda femoral, which is what you're looking for. Okay, hopefully I explained that to you well enough, and hopefully you got it. If you have any questions at all, go ahead and type them in the chat and we'll be happy to answer them for you. And if you don't, I think we're ready for our next topic here. We are going to be talking about aneurysms. Okay, so for aneurysms, basically it's just the swelling of the a vessel. In this case, what you're looking at is a swelling of an abdominal aorta, otherwise known as abdominal aortic aneurysm or AAA. Now, there are two main procedures that they'll do to correct this. They can either correct it by means of an open or direct repair, which you can see here on your A. So basically, they're going to open up the patient and then they're going to put the graft in there. And the minimally invasive one is going to be the endovascular repair, which you can see on your right. And that's what we're going to be talking about next. But first, I want you to look at this diagram here. It's very important for us to know the location or the target vessel that we're coding for when it comes to aneurysm and all these repairs. So what you will see here in your diagram is, your two main location. Aneurysms can happen in your in your thoracic or aorta or in the abdominal aorta. So in your thoracic aorta, your keywords would involve like ascending aorta, your aortic arch that can happen there, or descending thoracic aorta, okay? But most commonly for an AAA, your abdominal aortic aneurysm consists of here. And the determining factor for you when you're coding here is the suprarenal abdominal aorta, which you would find them in your probably in your description as upper. Okay, so basically what you're looking at is that renal artery determines whether you're coding for an upper or a lower, okay, abdominal aorta, abdominal aorta. So that's going to be your determining factor. So again, a suprarenal abdominal aorta are considered upper, and the infrarenal and all this part here is going to be your lower. Okay, so if you're gonna go ahead and take a moment to screenshot that one, and we're gonna go ahead and start with the types of repairs, and we're gonna start with the minimally invasive one, which is your endovascular repair of the abdominal aortic aneurysm. So basically what we're gonna do is a surgeon would typically thread in by use of X-ray in your femoral artery. They will thread in a graft. No, so they're going to put a catheter or something that will travel through your femoral artery all the way to your aorta, and usually that will um, thread in a graft, also called a stent graft, into the aorta, and then that will kind of like hold up your vessel, okay, your now fragile vessel when you have the aneurysm, like so. Isn't that amazing? So they don't even have to open you up for that procedure. Okay, so also what we need to talk about when we're coding for this is the type of prosthesis or the type of grafts or the stent that they're going to use. So what you see here is a tube. This one here is a bifurcated, and this one here is the aortouniiliac. Okay, so those are the terms that you might be seeing when you're coding for this. So let's go ahead and take a look at these guidelines. So there's a lot here, but you do have the time to read this for yourself. But I just want to go ahead and go over the ones that you need to pay attention to. So let's start over here on your left. So here are your codes for an endograft. That's for your treatment of the abdominal aortic aneurysm. So this is what you're going to be looking at to code for endograft. Also here, this is what you're looking for if you're coding for ilio-iliac endograft. That's for treatment of the isolated arteriopathology. So you're going to have to look at that code. And also for treatment of atherosclerotic occlusive disease in the iliac. So these are your codes that you're going to be looking at, 37221 and 37223. For a stent placement of the atherosclerotic disease in the aorta this time, this is going to be the codes that you're going to be looking at. Okay, now the use of modifier 50, you will use it for isolated bilateral iliac artery repair. That's your code 34707 or 34708 with modifier. So you can have to append that. When they talk about decompressive laparotomy for compartment syndrome after rupture, know that that's going to be reported separately. Now, this one, you will hear this a lot about the treatment zone. So remember that most of those intervention that happen in the treatment zone is going to be bundled in your endograft procedures. However, anything that's outside the treatment zone, those are most likely going to be coded outside. Okay. What else? Embolization may be reported separately, that talks about there. And endovascular repair is performed for ruptured aneurysm. So if you're looking for a ruptured aneurysm in the aorta or even in the iliac arteries, this is going to be what you're looking at as far as the codes. Okay. And then we're going to flip on to the next page. Oh, there's one more. 34709 is reported for the placement of extension of the prosthesis there. And then moving on here, so when we talk about 34709, just know that this can only be coded once per vessel treated. And 34710 and 34711 are reported for delayed placement. Here, your keyword there is for delayed, okay? Delayed placement. Again, 34710 and 34711 may only be reported only once per vessel treated. Your non-selective catheterization, watch out for that again. Like I said, those are typically bundled into your endograft procedure. However, if they are outside the treatment zone, so that's your keyword, if they are outside the treatment zone, then they will have to be coded separately. And that includes your fluoro as well. And 34709, these are your non-selective introduction of guide wires and catheter. Again, as long as they are in the treatment zone, they are bundled. If it is outside of the treatment zone, they are going to be coded separately. That's it. And just to summarize everything here, so what you're looking at as far as your coding for endovascular repairs. So if you want to go ahead and grab a pen, I'm going to simplify it down for you. So what you're going to be paying attention to first is that you have to know the location of treatment zones. So remember that diagram above, below renal arteries, okay? So you have to determine that. You have to watch out for the types of prosthesis. Is it uni, is it bifurcated or to unilateral iliac device, things like that. Those are your keywords that you're going to be watching out for. Know that the additional treatment within the treatment zone is bundled. Fluoro and radiographic supervision and interpretation are bundled as well. Non-selective catheterization is bundled. Ultrasounds are coded separately. PCI within the treatment zone is bundled. Procedures outside of the treatment zone are coded separately. Okay. All right. And I think that's it. Oh, and additional tips as well. True aneurysm involves all three layers, and pseudo aneurysm does not. And finally, again, I'm going to go back to the treatment zone is defined as those vessels that contain the endograft. So that's what you're going to be looking out for. All right. And I think that's it. But we do have one more thing that we need to discuss. This is another type of endovascular treatment, but this is for the fenesturated Oh, hold on. I think I went too far. Oh wait, I think this is still part of my my this one I missed, I think. So let me go over this pretty quickly, okay? So this just part of the endovascular repair again. I'm missing a little bit of more of the guidelines 34712. So again, this is for enhanced fixation device to the endograft. That's what you're looking at, and know that this is coded once per operative session. The vascular access requiring the use of closure devices are coded separately. Ultrasound guidance are going to be bundled when performed, okay? And what else? So extensive repair of an artery may also be reported separately. That's the extensive repair of an artery, okay? So you might want to be looking at this guideline as well. Creation of a prosthetic conduit utilizing a femoral artery is going to be bundled. Balloon angioplasty, that's your PCI, and or stenting at the ceiling zone of the endograft is going to be bundled. However, if it's outside the treatment zone, it's going to be coded separately. And other interventional procedures, again, outside the endograft treatment zone is going to be coded in addition to your procedure. And I think we pretty much summarized it all down. So hopefully I got everything there. And I already gave you your your summary for that guidelines for the endograft. Now, let me go ahead and talk to you about another type of endograft, which is called the fenestrated endograft, or the FEVAR, or FEVAR. So this fenestrated endograft basically is another type of a minimally invasive repair of the aneurysm. However, what's the difference here is that normally when they put endograft like so, there would be like a pretty much like they call it an adequate neck wherein they can place the graft. Sometimes an aneurysm would be like this, wherein if you can see, there's really not much wherein the graft can stick on or can be placed. So what they're actually going to do is, instead of using a typical endograft, they are going to be using this called fenestrated endograft, which is basically a stent or a graft like so, wherein their intention is going to cover or graft the vein all the way up to your renal artery, if it pertains to your renal artery there, meaning to say that they would actually have a fenestrated graft that has a window. That's to make access to the renal arteries like so, like that. And sometimes they will even go as far as put some stents to the renal arteries as well. So as you can see here, they go as far as to your upper renal artery there, and then that fenestrated, meaning to say that they have that graft has hole, and they would just basically put it in place so your blood can flow here, here, and of course the repair, majority of the repair that's here. So that's the difference between a endograft and a fenestrated endograft. Okay. Now they do have a separate set of guidelines here. So let me go over them with you. Again, if you have time, make sure that you go over this, read them through, but I just want to point your or drive your attention to the following significant procedures or guidelines for fenestrated endovascular repair. So that 34839 is going to be coded for the planning and the sizing of the patient specific fenestrated visceral aortic endograft. So they have to make sure to have a specific and the graph that will fit, you know, the vessel. Okay, because like I said, it's kind of like a personalized, because it has to fit on the arteries and such. Now when now code again 34839 also can only be reported when the physician spends a minimum of 90 minutes on performing that planning. Okay, this is only talking about the specific fenestrated endograft planning. Now watch out that these codes here are not going to be coded on the day before or the day of the fenestrated endovascular repair. Okay. What else? Fenestrated endovascular graft in the visceral aorta. You're going to be looking up at these codes. Fenestrated aortic repair. So this one is for visceral aorta. This one is for aortic repair. So these are the codes that you're looking at. using proximal endoprosthesis. Code 34845, all these codes here are used to code for endograft that spans from the visceral aorta. Okay, and here are your bundled codes. Okay, for the placement of the unilateral or bilateral docking limbs. Okay, and then I'm going to move on here. We have some more. Oh, here. These codes here, 34709, 34710, 34711 may not be reported. So they are going to be bundled into your the endovascular repair. Okay. And then I'm going to move along here. We have a little bit more. So codes 34841, these codes here, I'm not going to read it to you because I'm going to just take too much of your time. But just know that you have to watch out for this. This defines the total number of visceral and or renal arteries involved during that repair. And you're going to have to watch out for those and make sure that you're coding respectively. The introduction of the guide wires and catheters here are bundled. Again, when it's within the treatment zone, but however, if it's outside the treatment zone of the graft, then you're going to have to code it separately. Fluoro is going to be bundled. Exposure of the access vessels are reported separately for extensive repair of an artery. And other interventional procedures, so you might be watching out for that too, performed at the time of the fenestrated endovascular repair may be reported separately. So those can be embolization, intravascular ultrasound, and all those stuff. Okay. All right, how are you feeling about this? So let me just go over really quickly what you're going to be looking at as far as when you're coding for fenestrated endovascular repair. So your guidelines are as follows. You have to know, is it thoracic abdominal or is it an upper abdominal? Okay, so you have to know your angioplasty and PT, that's your PTCA, and fluoroscopy are bundled. And also upper abdominal aorta and the visceral aorta, which includes your celiac, superior mesenteric, and renal arteries. You have to pay attention to those keywords. And your thoracic abdominal aorta are those that extends from the aortic valve to the aortic segment, proximal to the celiac artery. And that's it. So basically, you're just going to be paying attention to your treatment zone. A lot of them are already bundled if they are within your treatment zone. If it's outside, most likely you're going to be coding them. So what do you guys think? Are you ready to code some scenarios here? Because I have some prepared for you. Actually, you know what? Before we get to those scenarios, let's go over the other one, the other type of repair for aneurysm. That would be the direct repair. Okay, so a direct repair is going to be when they actually, you know, they're going to actually cut the patient like so. They're going to open up your abdominal area in order for them to directly repair the aneurysm. Okay, and usually they will sew the graft like such, okay, to repair that swelling. Okay. And the reason why I want to get over this scenario because it's just really pretty small. So let's just go over them pretty quickly. We have your direct repair of aneurysm. So this just tells us that all these procedures from 35001 to 35152 already includes the preparation of the artery for anastomosis and also includes your endarterectomy. Okay. And that's it. See, didn't take that much long. So I'm, as promised, I have a scenario for you guys. So if you're ready, I'm gonna give this scenario up for you. So we have your answer choices: A, 33880, 34714, and 75956 with modifier 26. For B, we have 33880, 75956 with modifier 26. For C, we have 33881, 34714, 75957 with modifier 26. And for D, we have 33880, 92920, and 75956 with modifier 26. A 50-year-old firefighter suffered an aneurysm of the descending thoracic aorta. He arrives to the OR for repair of the aneurysm. The patient is prepped, draped, and properly anesthetized. A guide wire is inserted through the groin to access the femoral artery for road mapping of the aneurysm. The endovascular prosthesis is loaded onto the guide wire. Fluoroscopy, which aids guidance through the femoral artery into the iliac and up to the aneurysm. The prosthesis is positioned onto the device. The device is deployed and the prosthesis is secured in the ascending aorta and in the subclavian region. Under fluoroscopic guidance, balloon angioplasty is carried out to ensure the device is secured properly. The catheters is removed and the patient is ambulated to recovery. Which procedure best describes this encounter? And coders, if you're ready, I'm going to put myself on mute and we'll get the timer up for 1.5 minutes. I know you got this, coders. Good luck. All right, coders, are you ready with your answers? Okay, let's go over this one, and the answer is going to be B. And here is why. So if you look at our keywords here, we have a 50-year-old aneurysm, fluoroscopic AIDS guidance, and we have aneurysm. Sorry about that. Femoral artery. It's a it's not in proper order. Femoral artery, aneurysm, endovascular prosthesis. We have iliac and aneurysm prosthesis positioned onto the device, deployed prosthesis, secured ascending aorta, subclavian region, and fluoroscopic guidance angioplasty. Okay, so we're looking at these codes here, 3880 between that and 33881, which is the same family here. So let me just read to you the pairing code in the vascular repair of descending thoracic aorta. Exactly what we're looking for. This is for aneurysm, so we like this so far. It already involves the coverage of the left subclavian artery origin, okay, which is what's also here indicated there. And also initial endoprothesis plus descending through thoracic aortic extension if required to the level of celiac artery region. So we like this code so far, right? Because it's matching up our scenarios. Also, it has a parenthetical guideline that we always follow for radiological supervision and interpretation. You have to use that code 33880. Okay, so we did have that fluoro there as well. So we like this so far. However, if you look at that 33881, that it's indicating all of these procedures here. However, the difference, this is not involving the coverage of the left subclavian artery origin, but we did have that intervention there for those regions. So that one will eliminate C. Okay, now 34714 is for the open femoral artery exposure additional code, but this is only used for establishment of a cardiopulmonary bypass, which did not happen in our case there. So we can go ahead and um, eliminate that out. 9290 is your PTCA. Okay, and that is already bundled into your code, so we do not need that as well. So all you need is going to be that 33880 and the fluoro, which which was indicated in your parenthetical guidelines to code in addition to your procedure code. So your answer is going to be B. So great job for those of you who got that correct. If you missed something and you have questions, I'm going to go ahead and join you in the chat in a little bit. Meanwhile, I think it's time for me to turn this back over to you, Mrs. J.
I don't think it's me. Correct me if I'm wrong, Mrs. Tracy?
It is me, Mrs. J, and I'm over here talking my head off and I was on mute, so I apologize for that.
Awesome.
Okay, so all right, everyone. So I do have a quick explanation I want to talk to you all about before I hand it on over to Mrs. J. She has some more great things for you all. But let's go ahead real quick and talk about these heart and lung transplants. So heart and lung transplant, sometimes you'll hear it referred to as cardiopulmonary transplantation, is basically the simultaneous surgical replacement of the heart and the lungs, in, and that's performed on patients with end-stage cardiac and pulmonary disease, okay? And there are 3 possible procedures for these. So you have, we'll go over each one of these in detail. So the first one would be the cadaver donor. So this is basically the removal of the heart from the cadaver, and this can include it could be with or without the removal of the lungs as well. So pay attention to those codes. If you look at down below, it says C33930. That would be if you're removing the heart and the lungs, and 33940 is only if you're removing the heart. Okay. So pay attention to that. The backbench work, that's just basically the preparation of the cadaver donor. Okay, getting ready to transplant that. So that's just the preparation. And then the third one there, that's going to be the transplantation. Okay, so the recipient heart with or without lung allotransplantation. So again, pay attention to your documentation, whether it includes the removal or the transplantation of the lungs or not. Okay, and again, it refers you to code 33935 or 33945, depending on whether it's with or without lung transplantation. Okay. All right, and then also we have some codes for the heart implantation device. So this is basically an artificial heart, and that's just a device that replaces the heart and the lungs function, just that replaces the heart's function. I'm sorry about that. And they are usually used as just a temporary measure while the patient waits for a donor. And in some cases, it can permanently replace the heart if transplantation is not a possibility. However, this is not typical, as there are a lot of associated risks in doing so. Okay, but these would be the codes that you would reference for the artificial hearts. Okay, 33927 to 33929. All right, and I have a scenario for you. So here we go. A 33945, 33933, modifier 51, 33935, modifier 51. We have B 33935, 33933, modifier 51. C 33945, 33928, modifier 51, 33933, modifier 51, or D 33935, 33933, modifier 51, 33930, modifier 51. A 49-year-old disabled police officer with a history of smoking and heart failure and in need of a heart-lung transplant arrives to the OR for transplantation. The physician harvested the heart and lung grafts from a donor who was in a motorcycle accident and declared brain dead. Cardiectomy, pneumonectomy, and backbench work were performed on the cadaver. Then heart and lung allotransplantation was carried out on the recipient. Which procedure codes best describe this encounter? All right, everyone, you got a minute and a half and your time begins now. Good luck, coders. All right, all right. Get your answers in the chat. Give you just a few seconds to do so. And while you're doing that, I'm going to look at my answers. So I see in our answers here, our first listed codes, I'm either dealing with 33945 or 33935. So I'm going to look at the difference between those. And okay, let's go ahead and reveal the answer, shall we? The answer is going to be D. And my keywords are 49-year-old, history of smoking and heart failure, heart-lung transplant, physician harvested heart and lung grafts from the donor. We have a cardiectomy and a pneumonectomy and back bench that was performed. We have cadaver, heart and lung allotransplantation, and recipient. Okay, so we just have to determine what procedures were performed here. Okay, I see a transplant, I see a removal, I see backbench work. So it looks like all three of those procedures were performed there. All right, so let's go ahead and look at the difference first between 33945 and 33935. Okay, 33935 is for heart and lung transplant with recipient cardiectomy and pneumonectomy. I see cardiectomy, pneumonectomy, and I see heart and lung transplant. 33945 is just coding for a heart transplant with or without recipient cardiectomy. However, a heart transplant was performed, but we need to also code for that lung transplant, okay, because that was also done as well. Okay, so 33945 is not giving us what we need. So we're going to go ahead and we're going to get rid of answer A and answer C. Okay, so let's see what we have left. Now, am I coding for the backbench work? That's 33933. That's in both answer B and D. And it does definitely say in my scenario that we are, that backbench work was performed here. Okay, so that checks out. That's good because that's in both answers there. And what's different is this 33930. That's the donor cardiectomy. So that's basically the removal of the heart and lung from that cadaver. Okay, and that was performed. Okay, so in answer B, it's missing the removal code. So we're going to go ahead and get rid of answer B because there was a removal from the cadaver. Okay, so we definitely have to code for that. So get rid of B, and D is going to be the correct answer. And then we append modifier 51 just to indicate the multiple procedures that were performed. Alrighty. So how'd you all do on that one? Hopefully that makes sense. Hopefully you understand a little bit more on how to code these heart and lung transplants. And with that being said, I'm going to pass it on over to you, Mrs.Jay.
All right, let's get started. That's a great explanation, Mrs. Tracy. And coders, I'm looking at you in the chat. You're doing amazing. And you know what? I want to shout out all of those AMCI instructors. You are amazing. Thank you so much. All right, so now it's time to talk about, some people don't like to talk about catheter procedures or procedures, diagnostic studies. And these procedures are catheters that are inserted into the aorta and then fished up into an artery for the purpose of diagnosing some condition. So a lot of people get confused because they're not sure how to code it. So I'm going to hopefully make it easy. The first thing that you need to do is understand the anatomy of the aorta because the aorta is the pathway to all of the arteries. And very quickly, just want to tell you that when that catheter is inserted anywhere in the aorta, and look at this aorta. Doesn't it look like a monster? It looks like a monster to me. This looks like the head and this looks like the body. But it sort of does. This part of the aorta is the thoracic part, the upper body. And then it goes down and you've got your abdominal aorta. And then down here, you've got the lower part. So let's look at some key parts of this aorta that you should know. First, you've got common iliac arteries that branch off of the aorta. And look at them, they look like two little legs. So these are not the aorta, they're branching off. You need to know about it because you'll be coding for them. And this is considered a first order branch. It's considered a first order branch because it branches off of the aorta. The next thing you need to know, be able to identify on site, are these two little arms. I know they're very short, but these are the renal arteries. So you need to know that. And right, see this little red line in the back? This is your diaphragm because the upper part of the aorta, it separates the upper from the lower part of the aorta, the diaphragm. So upper diaphragm and lower diaphragm. So particularly when you are coding the upper diaphragm, you may be coding for cervical cerebral arteries, and they're up here. It's the hair, okay? So one takeaway that you should know, when you're coding for these diagnostic studies procedures, any catheter that is inserted into the aorta is considered a non-selective procedure, meaning the doctor is not selecting where that catheter is going to end up. It's just going right into the aorta and it doesn't leave the aorta. It could be anywhere. It becomes selective the moment it leaves. How does it leave? Well, they enter into the aorta and it can go up here or here or here or here or any of these branches. And the moment it starts moving into those branches, that is a selective catheterization, and we're going to take a look at the branches. All right, so Ms. Rochelle comes up with a lot of this imagery, and I'm going to tell you, I give her so much credit because they are so appropriate. And I've been using this image in front of you for a long time before I realized today, not today, like yesterday, how valuable it is. And hopefully, Ms. Rochelle, you're listening. Look at this. This is a color-coded image of the cervical cerebral artery. Cervical cerebral, we're talking about, it's going up neck and the head. Okay, so if you look, this gray portion, the gray is it's the artery, it's the aorta. And if you stick a catheter in that gray part, it's non-selective. Okay. Any branch directly off of the aorta becomes your first order. And look at it, it's this teal green. I love this. Thank you, Ms. Rochelle. It's your first order branch. And anything off of the first order is the second order. See, the light blue, it's off of the first order, so it's the second order. Anything off of the second order is red, and that's your third order and beyond. And pretty much that is how you get to your destination. And when you're coding for these cervical cerebral arteries in anything, where you end up is what you code. If you're fishing along, where you end up, that is your highest level, and that is where you code. So when we look at Appendix L and you're looking at your diagram, you see the thoracic aorta, that's the part of the aorta that is non-selective. Anything off of the thoracic will be your first order, and they will be in this section. Okay, there's your first order. All of these are in the section. And if we look, you've got your right brachiocephalic. That's your first order. And look, it's 36215, 36215. What else is 36215? It's hard to see. Your innominates are 36215. Okay, your right common carotid is 36216. So this is basically how it's done, and this is how you read it. But let me tell you, the key to coding for vascular families is reading and making sure that your codes are chunned properly. That is the best advice that I can tell you. You will need this Appendix L. I'm going to show you when you should reference this Appendix L. And pretty much it's for certain code families. Everything else you need to read. All right, coders, let's get busy and let's read these guidelines. And then we're going to review your guidelines. And then I'm going to show you how to chun, and then we're going to code. All right, first things first. Here are your diagnostic studies of the cervical cerebral arteries, 36221 through 36228. It has some bundled items into it. Your what's bundled. Well, what these codes describe are your non-selective and selective arterial catheter placement, your diagnostic imaging of the aortic arch, carotid and vertebral arteries, and then it, includes also the work of accessing the vessel, placement of catheters, contrast injection, fluoroscopy, radiological supervision and interpretation, and closure of the arteriotomy by pressure or application of an arterial closure device. All right. And then you've got code 36227. It's an add-on code, and your guidelines are here. I'm not going to repeat them because we're going to see them when we see the codes. And that's why I said reading is very, very important. 36228, this is your guideline. I'm not going to read it because it's going to be redundant in a moment. You got codes 36221 through 36226, your guidelines. Sorry, a little too fast. And then 36221, 36222, 23, 24, and 36225 and 26. When your bilateral carotid and or vertebral artery catheterization, they're telling you use modifier 50, and you use, instead of modifier 50, if you are visualizing or going to different territories within the body, you use modifier 59, and the code language kind of directs you. Your diagnostic angiography guidelines, and your it tells you do not report 36218 or 757 as part of diagnostic angiography of the extracranial and intracranial cerebral vessels. And you've got your 3D rendering guidelines. And finally, 76937 for your ultrasound guidelines. And you can find this all on page 260, page 259, and now on page 261 are your codes. And I know this is not a good image. I know that, but it was so important to have everything on the screen. If you open up your book, I'm sure you can follow along, but I want to show you some chun that will be very, very helpful. Remember, I said you need to distinguish if the codes are selective or non-selective. Selective means that that catheter did not go beyond that aorta. You know what, coders? You've got two non-selective codes. That's it. So if I were you, I would put the words non-selective. Also, this family, 36215 through 36218, you are to code the highest code, and you use Appendix L. And these codes represent codes or the anatomy above the diaphragm. Okay, and finally, you make sure that you code angiography separately. Okay. Next, on this side right here. These are the codes below the diaphragm. Your task when a doctor is describing the procedure, make sure that you code the highest artery, the highest meaning the highest number. And of the 36245, 36247 is your highest. Okay, it is the smallest and it is the most difficult to reach. All right, so again, these are the codes below the diaphragm, and you code angio separate. All other codes are, well, let's start with 36221. This is the code for catheter placement in the thoracic aorta versus 36200. This is placement into the aorta anywhere. But 36221 specifies the thoracic aorta, and it has a lot of things bundled in it. It bundles angiography, and it tells you that radiological supervision and interpretation are included in this code. 36222, this is selective catheter placement, meaning it left the aorta. And this is extracranial carotid circulation. They're sending the catheter to the extracranial carotid circulation. Angiography is bundled, and so is radiological supervision and interpretation. 36223. This is intracranial carotid circulation encoders. I highlighted these keywords because they are key. These should be the words that you should be looking for in your documentation. 36224, this is internal carotid arteries, and this is unilateral. 36225, this is selective catheter placement, subclavian or innominate arteries. 36226, these are vertebral arteries. Yes. 36227, of course, it's an add-on code, and it's for an external carotid artery. And look at all of these codes that are selective. They bundle. Don't forget, they're bundling the radiological supervision and interpretation. They're bundling angiography. And if you want to document that next to your code, then go right ahead. 36228, this is selective catheter placement. Each intracranial branch of the internal carotid or vertebral. All right, so we've already talked about these codes over here below the diaphragm. Let's go ahead and let's look at some more codes below the diaphragm. 36251, this is the first order main renal artery. So this is coding for main renal arteries. And don't forget 36252, this is your bilateral code. You don't have to append a 50 modifier because you've got a bilateral code. And 36253, this is the code for super selective catheter placement. One or more second order or higher renal artery branches. Okay, super selective of the renal arteries. We know these little arms are your renal arteries. So what is super selective? If you said above the renal arteries, indeed that is correct. So I think that's all that I have in terms of documentation. Yes, it is all, but let me go ahead and let's read the guidelines. All right. Guideline number 1, is it selective or non-selective or super selective? Guideline number 2, is it upper diaphragm or lower diaphragm? Guideline number 3, is it first, second, and third vascular order? You're going to need to know if it's first, second, or third vascular order when we are talking about these two right over here. These two families, this family and this family. All other codes specify exactly what we're coding for. So if we're going all the way up and we're coding these families, one of these families you're going to need to know, is it first, second, or third order? And always code the highest order. Third is the highest, followed by second, then first. Also, interventional angiography, fluoroscopy, radiological supervision and interpretation, closure of the aortotomy by pressure are coded. They are all bundled in these codes. However, in these family codes, you're going to have to code some of them. Okay, so make sure you read the documentation. And that is pretty much it. Oh, yeah, I do have a couple of other things. When you're coding for, let's see, anytime you're coding for bilateral procedures, make sure that you use 50 modifier. It has to be the same exact procedure on the opposite side. However, if it's not the same exact procedure, make sure that you use 59, excuse me. And I think that's it. All right, coders. And if you need to play back, definitely I encourage you to do it. And now let's do our first and only scenario. I'll read the answers first. A, 36223. B, 36224. 36215 with a 59 modifier. C, 36224, 36228, and D, 36224 with a 50 modifier. A 59-year-old female security guard with a history of atherosclerosis arrives to the OR for bilateral catheter placement of the internal carotid artery. Angiography was performed on the intracranial carotid vessels situated on both sides. Which procedure codes best describe this encounter? Okay, coders, you have a minute and a half. Okay, there's your answer, coders. If you said D, outstanding. Well, please forgive that little ding in the background. We have all kinds of reminders and things to kind of keep me on task. So I apologize. All right. So the answer is D, but you know what, coders? You probably will learn something. Yeah. All right. We have our keywords. You've got a 59-year-old history of atherosclerosis, and the patient arrives for bilateral catheter placement of the internal carotid artery. Angiography was performed on the intracranial carotid vessel situated on both sides. All right, so what happened? What took place? And it's really important that you don't get caught up in this language. This is not an area where you can skim. Make sure you read the code very carefully and you will get the answer. So let's begin with what we're coding. We're coding for bilateral catheter placement of the internal carotid. So if you look at 36223, it's coming up red, and red means wrong. It's wrong because although this is selective catheter placement, it is selective catheter placement for the common carotid or innominate, unilateral, any approach. So common carotid or innominate. Didn't we just say we're coding for the internal carotid? So right away, we're going to eliminate A. Next, we like 36224 because this is the code for selective catheter placement, internal carotid artery. And let's look at this language, unilateral, with angiography of the ipsilateral intracranial carotid circulation and all associated radiological supervision and interpretation. And this includes angiography of the external carotid and cervical cerebral arch when performed. All right, coders, this code sounds like it all. And you know what? It is because it's doing everything. Remember, look at our language. Angiography was performed on the intracranial carotid vessels. That code is coding for it all. It's coding for the angiography of the ipsilateral intracranial carotid circulation and all associated radiological supervision and interpretation. So it's coding for all of it, but just one side. So that brings us to look at this parenthetical guideline. It tells you do not report 36224 in conjunction with 36215. 36215 is coded with B. 36224, 36215. That's not correct because the guideline tells you it is incorrect. Next, 36224 is also coded with 36228. And this, and some of you, if you were to select a wrong answer, this will probably be it. But let's look at this forensically. 36228 is wrong because this is selective catheter placement. Each intracranial branch, we are doing that. We had a catheter placement of the internal carotid. However, angiography was carried out on the intracarotid vessels. So some people might have gotten that language a little confused because it says each intracranial branch of the internal carotid or vertebral arteries. That didn't happen. So you know what? We're going to eliminate C. And our answer is D, 36224. And because this code is coding for unilateral with angiography of the ipsilateral, that's only one side, okay, the whole one side, and this procedure is coding, well, needs to be coded for bilateral. So we do append a 50 modifier, and our answer is D. All right, coders, how do you feel? Are you professionals now when coding vascular families? If you do, if you need more, my suggestion is to watch the playback and slow it down a little bit. And if that doesn't do it, I would contact AMCI customer service. Go ahead and look in the discussion, click on customer service, and ask them how you can see the AMCI Cardiovascular Lecture Series, because I tell you, it is gold. All right, I think I'm finished. And you know what, coders? If you learned something, that is priceless. If you have questions, go ahead and type them in the chat. I am coming in to help. And Mrs. Tracy, I'm handing it off to you.
Okay, I think I'm talking and I'm on mute. I'm so sorry. I'm going on and on. But anyways, what I was saying is having that information that Mrs.Jay just went over with you, especially that chun, is just invaluable. It helps tremendously. So as Mrs.Jay said, if you weren't able to keep up, that's okay. You can always go back, watch the playback, press pause as you need to, and really, really notate those pages. It really helps. Thank you so much, Mrs.Jay. All right, so we are winding down now. I'm going to talk about our last subject of today, and then we'll be finished. So we're going to talk about central venous access procedures. Okay, so a central venous access device is a catheter that is basically placed into a large vein. These catheters are typically put into patients who require frequent access to the bloodstream. And it's important to note where the tip of that catheter ends up. So let's go ahead and talk about some of the guidelines here. Okay, so the very first guideline up here, just watch out for this. You see the little eyes. To qualify as a central venous access catheter or device, the tip of that catheter or device must terminate in the subclavian, brachiocephalic, innominate, or iliac veins, the superior or inferior vena cava, or the right atrium. Sorry, I'm having difficulty speaking. The venous access device can either be centrally inserted through jugular, subclavian, femoral vein, or inferior vena cava catheter entry site, or they can be peripherally inserted, okay, such as the basilic, cephalic, or saphenous vein entry site, okay? The device may be accessed for use either via exposed catheter, which is just on the outside of the skin, or also they can be accessed through a subcutaneous port or subcutaneous pump. And that's really important to note because you just really need to pay attention in the documentation, whether you're coding for centrally insert it, peripherally insert it, whether it's tunneled, non-tunneled, whether it's being accessed through a port or a pump. So just those are just some guidelines to remember, okay? And there are 5 categories, so just make sure that you're coding in the right place. We have codes for insertions, repairs, partial replacements, complete replacements, and removals. All right, some more things to pay attention to here is for the repair, partial, catheter only, replacement, complete replacement, or removal of both catheters placed from a separate venous access device or multi-catheter device with or without subcutaneous ports or pumps. You want to use the appropriate code describing the service with frequency of 2. And also, some more guidelines to pay attention to. If you are coding for a removal, if the device is removed and a new one is placed, then you're going to have 2 codes, okay? That should be reported there. If you are coding for, or if there is fluoro guidance for centrally inserted, that is going to be, when imaging guidance is used for centrally inserted central venous catheters for gaining access to the venous entry site and or for manipulating the catheter into final central position, you would use the imaging guidance codes from the radiology section 76937, 77001, okay? Those can be reported separately. However, we do not report those codes in conjunction with the following. So you'll see 76937 and 77001 cannot be used with this certain code range here. And that is because if you look at these codes, I believe those are all for PIC peripherally inserted catheters, and those include the fluoro already. So of course you would not code an additional fluoro because it's already included there. Alrighty, and there's just a little example of a central location here and a peripheral location. Okay, that's in the arm. And then also pay attention for a tunneled and non-tunneled catheter. Basically, a tunneled catheter is just placed under the skin and through subcutaneous tissue to the site that's needing access. And a non-tunneled is just through a short tract, basically from the skin entry site directly into the site that needs to be accessed. Okay, so those are two very key terms that you want to remember as well: tunneled and non-tunneled. Okay, and there you go. And there's a little example there of tunneled and non-tunneled for you. All right, and then some guidelines here. Again, you want to know if you're dealing with central or peripheral, whether it's selective or non-selective, whether it's tunneled or non-tunneled. Age is really important here. So as you notice when we go over our keywords with you all, we always have an age as part of our keyword, just because some of these codes are age driven. So these codes right here are age driven. So pay attention to the age of the patient, and also if you're dealing with a PIC, is it with or without imaging, okay? And then also on page, let me see here, I think it's page 270, you have a table that helps you. If you're into tables, there's a central venous access procedures table that will help you to code these central venous access devices, okay? And there you go. And speaking of this table, go ahead and turn to that page 270. And I have a scenario that a little example here I want to go over with you guys. So I'll give you a little bit of time to answer this one. But if we have a 2-year-old patient that was diagnosed with cellulitis and requires a catheter, the catheter was placed on his foot to prevent him from removing the catheter. What procedure code would we use for this encounter? So I'm going to place myself on mute, and I'll give you guys, just using this table, see if you can come up with the code, and I'll give you about a minute, okay? Your time begins now. Okay, go ahead and place your answer that you came up with here in the chat, and let's go over this one. So first of all, my keywords, we have a 2-year-old. Remember I said these are age driven, and as you can see here in this table, we are dealing with, let's just go over this real quick. The categories up at the columns up at the top, we have non-tunneled, tunneled, we have central tunneled, tunneled with ports, tunneled with pump, we have peripheral, and then we have age, less than 5 years, greater than or equal to 5 years, or any age, okay? So here's our keywords. We have a 2-year-old patient, has a catheter in the foot, and that's pretty much all I need here to figure this out. Now, because I see the first thing is, I want to know, is this central or peripheral? And since this catheter is placed in the foot, it is going to be peripheral, okay? So if we look at the on the side right over here, we have catheter without imaging, catheter with bundled imaging guidance, or device, okay? So we're going to be right here, catheter without imaging guidance, because it does not say that there was imaging guidance performed. And then we're going to go over to peripheral, okay? So that's the category that we want to be in right here. And then it comes down to the age. This patient is 2 years old, so we're going to be coding right here for less than 5 years. And this patient didn't have a port or pump, so we're going to be coding this right here at 36568, okay? So again, catheter without imaging, peripheral, less than 5 years, without port or pump gives us code 36568, and we're going to go ahead and look that up. 36568 is for insertion of peripherally inserted central venous catheter or PIC without subcutaneous port or pump. Doesn't mention a port or pump. Younger than 5 years of age. That all checks out to what it says in our scenario right there. So this is going to be our code. Okay, so 36568 is the answer. You got that correct? Great job. If you didn't, but you see your mistake and you were following along with this, then that's priceless, as Mrs.Jay would say. Okay, so let's go ahead, and I think I have one final scenario for you. So if you are ready, here we go. We have our answers: A, 36556, B, 36557, C, 36558, or D, 36561. A 63-year-old stage 4 male breast cancer patient arrives to the surgery center today for central venous catheter placement to more effectively enable the administration of his chemotherapy treatments. The patient is draped and placed in supine position. Anesthesia is administered. Using a needle, a catheter is placed into the internal jugular vein. The skin of the chest is incised to create a tunnel in the soft tissue. Using a guide wire, a catheter is passed through the tunnel, placing the tip of the catheter into the right subclavian vein. The end of the catheter, outside of the body, is covered with local soft tissue and secured with sutures. Electrocautery achieved hemostasis. The site was irrigated with antibiotics. Which procedure code best describe this encounter? And I'll go ahead and give you a minute and a half, and your time begins now. Good luck, coders. Okay, how'd you do? Go ahead and place your answers in the chat. And looking at my answers here, it looks like they're all pretty, these codes are all pretty close together. So we're just gonna have to do some forensic reading here. So get those forensic reading glasses on and let's go for it. Our answer is going to be C. Okay, let's find out why. I have my keyword, 63-year-old, male breast cancer, central venous catheter placement, chemotherapy, catheter again, internal jugular vein, create tunnel, right subclavian vein. That's pretty much all I need. Okay, so let's go ahead and look at these codes. So first of all, I'm going to look at answer A, 36556. And this is for insertion of non-tunneled, centrally inserted central venous catheter. That this is for age 5 years and older. So I like the age. However, why is this one incorrect? If you can type it in the chat real quick and let me know what keyword there makes this one incorrect. Give you 1 second to go ahead and do that. And I'm going to tell you right now, this code is incorrect because this is for insertion of a non-tunneled CVC, okay, or central venous catheter, okay? And it clearly states in our scenario that this was tunneled, okay? So based off of that keyword there, we can go ahead and eliminate A. All right, so that's why it's really important to follow those keywords. Okay, now looking down at 36557, insertion of tunneled centrally inserted central venous catheter without subcutaneous port or pump, younger than 5 years of age. Okay, so this one says it's tunneled. It says it's without a subcutaneous port or pump, which I don't see one mentioned in our scenario. However, following those keywords again, what is the age? The age is younger than 5 years of age. Our patient is 63. So again, this is an age-driven code. So that is going to be incorrect. So we can go ahead and get rid of B. Okay. Next, we're gonna go to 36558, sorry. And that basically follows the same parent over here, insertion of tunneled centrally inserted central venous catheter without subcutaneous port or pump. But this one is for age 5 years or older. Okay, that's right where we want to be. I like that code. Okay, but we always have to do our due diligence and make sure that we check everything. So let's look at 36561. Okay, and that's for insertion of tunneled centrally inserted central venous access device with subcutaneous port, age 5 years or older. So the thing with this one, it's coding for a subcutaneous port. However, in our scenario, there's no mention of a port, so we're definitely not going to code what we don't see in our documentation. We're only going to code what we see. So that one is going to be incorrect, and that makes C the final answer. So go ahead and talk to me in the chat. Let me know how you did on this one. If you see your mistake or if you got that correct, great job. Okay, so that was our last scenario of the day, and I'm going to move along, and I have a couple more things for you, and we have to reveal our winner as well. So first of all, go ahead. This is a little matching exercise for you all. If you'd like to take advantage of this, go ahead. I'll give you a second if you want to take a snapshot or something before I reveal the answers. So go ahead and do that, and I'm going to reveal the answers now. And I think after today, you all are going to be cardio geniuses. I know we covered a lot, and very well worth it. This is a big section, so I hope you all learned something today. And here's some anatomy, here's some free resources for you, anatomy resources. If you want to go ahead and take a snapshot of that as well. Okay, and if you want some additional instruction on PCI, go ahead and go to YouTube. We can place that in the chat for you all. We'll place that link in the chat for you on the PCI. So team, if you don't mind, go ahead and place that link in the chat for our wonderful students here. And I think that's it. Next week, we're covering the digestive system, and I'm going to bring Mrs.Jay back into the conversation. Hi, Mrs.Jay.
Hi, how are you? You rocked that ship, didn't she? Didn't she, coders? This was awesome. Awesome instruction. And you know what? Yes, next week we will talk about digestive system. This is a popular section. A lot of people are comfortable with it. So we're comfortable with it too. But before we go, I want to move on and announce the winner. Shekinah Davis, or Shakina, not sure how to pronounce your name. Go ahead, write your name phonetically in the chat so I can say it. Shekinah Davis, congratulations. You are the winner of the AMCI Lecture Series. What does that mean? That means that you have access to the AMCI private lectures. You'll get to see our full collection of evaluation and management, and that includes auditing. You'll see our full collection of ICD-10 in integumentary through nervous system. Yes, we've done integumentary, and we're going to do through nervous system, but the private lectures is private, and they're private for a reason, because that is our best content. Stuff and concepts are broken down to they're broken down very simply for you to understand. And also the guidelines are presented. and it's presented in a way that's very, very basic, and it's easy to understand, and it's not necessarily for an advanced coders, it's for all coders, and it's amazing. It's our best work. All right, let's
Yes,
move
and I just
on.
have to add to that, Shekinah Davis, congratulations, and you just struck gold.
Yes, she did. Well, welcome to the family. All right. So, if you didn't win this week and you want to win an AMCI lecture series, this is how you do it. Comment below. Comment on the video below this video. Let us know what you learned today in this presentation. What did you learn from this presentation? We want to know. Then, in the chat, there is a link. You need to click on that link and complete that form, and then we will put you in the drawing for the next AMCI lecture series. So we won't announce the winner next week. We're going to announce the winner the 6th week. So you have an opportunity to get your response in. If you put in a response, if you complete one of the forms this week, you can complete it again next week, and you have a double chance of winning. Yes, yay. So congratulations again, Shekinah, and good luck to all of you. And I think, boop. All right, so if you want more information, you want to know what else we have, if you need more instruction, contact our customer service department, www.amcicoding.com, and they will get back to you. You can also schedule a phone chat if you want. Also, if you are a novice and this was just too difficult, we have something for you. Or if you know someone that wants to get into coding, we have something for you. We have a free introduction to medical coding course. Just contact customer service and get signed up. And I think that's it, Mrs. Tracy.
I think that is it. Yes. Thank you, everyone, so much for joining us today for cardio. It always feels better when we tackle a little bit of cardio. I know it can be a little bit of a challenge, even for myself. So it always feels good coming out of cardio, and I always learn something. And I did learn something today. So I hope you all did too. And
Mhm.
thank you, Mrs.Jay and Miss Rochelle. You guys did an amazing job today.
Thank you, Mrs. Tracy. And let's thank our instructors, our AMCI instructors, Miss Angela, Miss Sarah, Miss who else is in there?
Miss
Help me out.
Anna, Miss,
Anna.
oh, you said Miss Sarah, Miss Valentina, Miss
Miss
Tiffany. Thank you
Tiffany,
all
yes.
so much.
Miss
Yeah,
Jody, good.
Miss Jody, yes.
yes. You all are amazing. Thank you. And I don't think Miss Mia's with us this week or Miss Bennett, but you know what? We are happy we're happy whenever you bless us with your or grace us with your presence. All right, so that's all I have to say. Thank you for Miss Rochelle and Mrs. Tracy for being a part of the best team in the whole wide world, and we'll see you all next week. Don't forget to click on that link in the chat to win your lecture series.
Yes,
We'll
good
be
luck,
next.
coders.
Can hardly wait.
Me too. Good luck until next week. Bye.
Bye, everyone.